Pharmacy Services. Appendix PP, Regulation Section 483.45, tags F755 through F761. Begin reading. Tag F755. Section 483.45, Pharmacy Services. The facility must provide routine and emergency drugs and biologicals to its residents, or obtain them under an agreement described in Section 483.70F. The facility may permit unlicensed personnel to administer drugs if state law permits, but only under the general supervision of a licensed nurse. Section 483.45A Procedures. A facility must provide pharmaceutical services including procedures that assure the accurate acquiring, receiving, dispensing, and administering of all drugs and biologicals to meet the needs of each resident. Section 483.45B Service Consultation. The facility must employ or obtain the services of a licensed pharmacist who. Section 483.45B1 provides consultation on all aspects of the provision of pharmacy services in the facility. Section 483.45B2 establishes a system of records of receipt and disposition of all controlled drugs in sufficient detail to enable an accurate reconciliation. And Section 483.45B3 determines that drug records are in order and that an account of all controlled drugs is maintained and periodically reconciled. Intent Section 483.45A and B1, 2, and 3. The intent of this requirement is that, in order to meet the needs of each resident, the facility accurately and safely provides or obtains pharmaceutical services, including the provision of routine and emergency medications and biologicals, and the services of a licensed pharmacist. The facility utilizes only persons authorized by state or local regulation or other guidance to administer medications during the course of employment by a facility. The licensed pharmacist collaborates with facility leadership and staff to coordinate pharmaceutical services within the facility, guide development and evaluation of pharmaceutical services procedures, and help the facility identify, evaluate, and resolve pharmaceutical concerns which affect resident care, medical care, or quality of life, such as the provision of consultative services by a licensed pharmacist as necessary, and coordination of the pharmaceutical services if multiple pharmaceutical service providers are utilized, e.g., pharmacy, infusion, hospice, prescription drug plans, PDP. The facility, in coordination with the licensed pharmacist, provides for a system of medication records that enables periodic accurate reconciliation and accounting for all controlled medications, prompt identification of loss or potential diversion of controlled medications, and determination of the extent of loss or potential diversion of controlled medications. Note, although the regulatory language refers to drugs, the guidance in this document generally will refer to medications, except in those situations where the term drug has become part of an established pharmaceutical term, e.g., adverse drug event, adverse drug reaction, or consequence. For purposes of this guidance, references to the pharmacist mean the licensed pharmacist, whether employed directly by the facility or through arrangement. Definitions, Section 483.45. Definitions are provided to clarify terminology related to pharmaceutical services and the management of each resident's medication regimen for effectiveness and safety. Acquiring medication is the process by which a facility requests and obtains a medication. Biologicals are made from a variety of natural sources, human, animal, or microorganisms. Biologicals are used to treat, prevent, or diagnose diseases and medical conditions. They may include a wide range of products such as vaccines, blood and blood components, allergenics, somatic cells, gene therapy, tissues, and recombinant therapeutic proteins. Controlled medications are substances that have an accepted medical use medications, which fall under U.S. Drug Enforcement Agency D Schedules Roman IIV, have a potential for abuse, ranging from low to high, and may also lead to physical or psychological dependence. Dispensing is a process that includes the interpretation of a prescription, selection, measurement, and packaging or repackaging of the product as necessary, and labeling of the medication or device pursuant to a prescription/order. Disposition is the process of returning and or destroying unused medications. Diversion of medications is the transfer of a controlled substance or other medication from a lawful to an unlawful channel of distribution or use, as adapted from the Uniform Controlled Substances Act. Pharmaceutical services refers to the process, including documentation, as applicable of receiving and interpreting prescribers' orders. Acquiring, receiving, storing, controlling, reconciling, compounding, e.g. intravenous antibiotics, dispensing, packaging, labeling, distributing, administering, monitoring responses to, using and or disposing of all medications, biologicals, chemicals, e.g. povidone iodine, hydrogen peroxide. The provision of medication-related information to healthcare professionals and residents. The process of identifying, evaluating, and addressing medication-related issues, including the prevention and reporting of medication errors, and the provision, monitoring, and or the use of medication-related devices. Pharmacy assistant or technician refers to the ancillary personnel who work under the supervision and delegation of the pharmacist, consistent with state requirements. Receiving medication, for the purpose of this guidance, is the process that a facility uses to ensure that medications, accepted from the facility's pharmacy or an outside source, e.g. vending pharmacy delivery agent, Veterans Administration, family member, are accurate, e.g. doses, amount. Reconciliation, for the purpose of this guidance, refers to a system of record-keeping that ensures an accurate inventory of medications by accounting for controlled medications that have been received, dispensed, administered, and or including the process of disposition. Guidance Section 483.45. The provision of pharmaceutical services is an integral part of the care provided to nursing home residents. The management of complex medication regimens is challenging and requires diverse pharmaceutical services and formal mechanisms to safely handle and control medications, to maintain accurate and timely medication records, and to minimize medication-related adverse consequences or events. The overall goal of the pharmaceutical services system within a facility is to ensure the safe and effective use of medications. Preventable medication-related adverse consequences and events are a serious concern in nursing homes. The U.S. Department of Health and Human Services HHS Office of the Inspector General issued a report in February 2014, Adverse Events in Skilled Nursing Facilities, National Incidence Among Medicare Beneficiaries, OEI 06-11 to 00370. The OIG found that 1 in 3 SNF residents experienced an adverse event or temporary harm event. 37% of these adverse events were related to medications, and 66% of all medication-related events were preventable. Medication-related adverse events included excessive bleeding due to anticoagulant use without adequate monitoring and acute hypoglycemia. Consequences of medication-related adverse events included a prolonged SNF stay, hospitalization, life-sustaining interventions, permanent harm, and death. Factors that increase the risk of adverse consequences associated with medication use in the nursing home setting include complex medication regimens, numbers and types of medication used, physiological changes accompanying the aging process, as well as multiple comorbidities. The consultative services of a pharmacist can promote safe and effective medication use. A pharmacist in collaboration with facility staff, establishes, evaluates, and coordinates all aspects of pharmaceutical services provided to all residents within a facility by all providers, e.g., pharmacy, prescription drug plan, prescribers. A pharmacist can also help in the development of medication-related documentation procedures, such as identification of abbreviations approved for use in the facility, and can help guide the selection and use of medications in accordance with the authorized prescriber's orders, applicable state and federal requirements, manufacturer's specifications. Characteristics of the resident population and individual resident conditions. Providing pharmaceutical consultation is an ongoing, interactive process with prospective, concurrent, and retrospective components. To accomplish some of these consultative responsibilities, pharmacists can use various methods and resources, such as technology, additional personnel, e.g., dispensing pharmacists, pharmacy technicians, and related policies and procedures. Numerous recognized resources address different aspects of pharmaceutical services and medication utilization, such as U.S. Department of Health and Human Services, DHHS, Food and Drug Administration, FDA, find information about a drug, information on FDA-approved drugs released for sale on the market. The American Society of Health System, Pharmacists ASHP, http://www.ashporg. The National Institutes of Health U.S. National Library of Medicine Medline Plus, https://medlineplusgov/druginformation HTML. AMDA, the Society for Post-Acute and Long-Term Care Medicine, American Medical Directors Association, https://paltcorg/. The National Coordinating Council for Medication Error Reporting and Prevention, NCCMERP, https://www.nccmerporg/. American Society for Parenteral and Enteral Nutrition, ASPEN, https://www.nutritioncareorg/. Note: references to non-CMS sources do not constitute or imply endorsement of these organizations or their programs by CMS or the U.S. Department of Health and Human Services, and were current as of the date of this publication. A. Provision of routine and / or emergency medications. The regulation at 42 CFR 483.45 requires that the facility provide or obtain routine and emergency medications and biologicals in order to meet the needs of each resident. Facility procedures and applicable state laws may allow the facility to maintain a limited supply of medications in the facility for use during emergency or after-hours situations. Whether prescribed on a routine, emergency, or as needed basis, medications should be administered in a timely manner. Delayed acquisition of a medication may impede timely administration and adversely affect a resident's condition. Factors that may help determine timeliness and guide acquisition procedures include availability of medications to enable continuity of care for an anticipated admission or transfer of a resident from acute care or other institutional settings. Condition of the resident, including the severity or instability of his or her condition, a significant change in condition, discomfort, risk factors, current signs and symptoms, and the potential impact of any delay in acquiring the medications. Category of medication, such as antibiotics or analgesics, availability of medications in emergency supply, if applicable, and ordered start time/date for medication. Procedures should identify how staff, who are responsible for medication administration, ensure each resident has a sufficient supply of his or her prescribed medications. For example, a resident who is on pain management has an adequate supply of medication available to meet his or her needs. At a minimum, the system is expected to include a process for the timely ordering and reordering of a medication, monitor the delivery and receipt of medications when they are ordered, and determine the appropriate action e.g., contact the prescriber or pharmacist when a resident's medication S is not available for administration. Note: facility staff may encounter situations in which a medication is not available in the resident's supply or the facility's emergency medication supply, and then decide to borrow medications from another resident's supply. This practice of borrowing medications from other residents' supplies is not consistent with professional standards and contributes to medication errors. Concerns about whether the facility has a system in place to ensure each resident has a sufficient supply of medications for timely administration should be cited under this tag pharmacy services F755. However, if staff borrow any medication from another resident's supply due to failure to order the medication and or not following the facility's system for reordering medications, refer to Section 483.21b3, F658, Services Provided Meet Professional Standards. Instances of borrowing, as described in this paragraph, would not be considered to be drug diversion. Foreign acquired medications. It has been reported that some residents and or facilities may be obtaining medications from foreign sources. Medications obtained from foreign sources may present safety issues since they have been manufactured or held outside of the jurisdiction of the United States U.S. regulatory system. These medications may not be safe and effective for their intended uses. The Federal Food, Drug, and Cosmetic Act, FFDCA, strictly limits the types of drugs that may be imported into the U.S. Medications imported into the U.S. may violate the FFDCA if they are unapproved by the FDA, labeled incorrectly, or dispensed without a valid prescription. The facility should, in collaboration with the pharmacist, assure that medications are provided or obtained from approved sources and do not violate the FFDCA. If it is determined that the facility is providing obtaining foreign medications that are not FDA approved for use by the residents, the state agency must make referrals to appropriate agencies, such as the FDA. Depending on the medication classification, the Drug Enforcement Administration, State Board of Nursing, State Board of Pharmacy, and the State Licensure Board for Nursing Home Administrators. B. Pharmaceutical Services Procedures. The pharmacist, in collaboration with the facility and medical director, helps develop and evaluate the implementation of pharmaceutical services procedures that address the needs of the residents, are consistent with state and federal requirements, and reflect current standards of practice. These procedures address, but are not limited to, acquiring, receiving, dispensing, administering, disposing, labeling, and storage of medications, and personnel authorized to access or administer medications. Acquisition of medications. Examples of procedures addressing acquisition of medications include availability of an emergency supply of medications, if allowed by state law, including the types or categories of medications, amounts, dosages/strengths to be provided, location of the supply, personnel authorized to access the supply, record keeping, monitoring for expiration dates, and the steps for replacing the supply when medications are used. When, how to, and who may contact the pharmacy regarding acquisition of medications, and the steps to follow for contacting the pharmacy for an original routine medication order, emergency medication order, and refills. The availability of medications when needed, that is, the medication is either in the facility in the emergency supply or obtained from a pharmacy that can be reached 24 hours a day, 7 days a week. The receipt, labeling, storage, and administration of medications dispensed by the prescriber, if allowed by state requirements. Verification or clarification of an order to facilitate accurate acquisition of a medication when necessary, e.g., clarification when the resident has allergies to, or there are contraindications to the medication being prescribed. Procedure when delivery of a medication will be delayed, or the medication is not or will not be available, and transportation of medications from the dispensing pharmacy or vendor to the facility consistent with manufacturer's specifications, state and federal requirements, and standards of professional practice to prevent contamination, degradation, and diversion of medications. Receiving medication. Examples of procedures addressing receipt of medications include how the receipt of medications from dispensing pharmacies and family members or others, where permitted by state requirements, will occur, and how it will be reconciled with the prescriber's order and the requisition for the medication. How staff will be identified and authorized in accordance with applicable laws and requirements to receive the medications, and how access to the medications will be controlled until the medications are delivered to the secured storage area, and which staff will be responsible for assuring that medications are incorporated into the resident-specific allocation/storage area. Dispensing medication. Examples of procedures to assure compatible and safe medication delivery, to minimize medication administration errors, and to address the facility's expectations of the in-house pharmacy and / or outside dispensing pharmacies include delivery and receipt, labeling, and the types of medication packaging, e.g., unit dose, multi-dose vial, blister cards. Administering medications. Examples of procedures addressing administration of medications include providing continuity of staff to ensure that medications are administered without unnecessary interruptions. Reporting medication administration errors, including how and to whom to report, authorizing personnel consistent with state requirements to administer the medications, including medications needing intravenous administration. See Authorized Personnel section within this document. Assuring that the correct medication is administered in the correct dose, in accordance with manufacturer's specifications and with standards of practice. To the correct person via the correct route in the correct dosage form and at the correct time, defining the schedules for administering medications to maximize the effectiveness, optimal therapeutic effect of the medication, for example, antibiotics, antihypertensives, insulin, pain medications, proton pump inhibitors, metered dose inhalers, and medications via enteral feeding tubes. Prevent potential significant medication interactions, such as medication-medication or medication-food interactions. And honor resident choices and activities as much as possible, consistent with the person-centered comprehensive care plan. Defining general guidelines for specific monitoring related to medications when ordered or indicated, including specific items to monitor, e.g., blood pressure, pulse, blood sugar, weight, frequency, e.g., weekly, daily, timing, e.g., before or after administering the medication, and parameters for notifying the prescriber. Defining pertinent techniques and precautions that meet current standards of practice for administering medications through alternate routes, such as eye, ear, buccal, injection, intravenous, atomizer/aerosol/inhalation therapy, or enteral tubes. For example, for enteral feeding tubes, define procedures including but not limited to types of medications that may be safely administered via enteral feeding tube. Appropriate dosage forms. Techniques to monitor and verify that the feeding tube is in the right location, e.g., stomach or small intestine, depending on the tube before administering medications. And preparing drugs for enteral administration, administering drugs separately, diluting drugs as appropriate, and flushing the feeding tube before, between, and after drug administration. Including the amount of water to be used for the flushing and administration of medications, and obtaining physician/practitioners' order to address a resident with fluid restrictions. Note: enteral feeding tube practice recommendations may be found in Aspen Safe Practices for Enteral Nutrition Therapy, https://Aspen Journals Online Library Wiley.com/doi/full/10.1177/014860711667303. References to non-CMS sources do not constitute or imply endorsement of these organizations or their programs by Department of Health and Human Services and were current as of the date of this publication. Documenting the administration of medications, including the administration of routine medication and, if not administered, an explanation of why not. The administration of as-needed PRN medications, including the justification and response. The route, if other than oral intended route, may be preprinted on medication administration record MAR, and location of administration sites, such as transdermal patches and injections. Providing accessible current information about medications, e.g., medication information references and medication-related devices and equipment, e.g., user's manual for all staff involved with the medication administration process. Clarifying any order that is incomplete, illegible, or presents any other concerns prior to administering the medication, and reconciling medication orders including telephone orders, monthly or other periodic recapitulations, and MAR, including who may transcribe prescribers' orders and enter the orders onto the MAR. Disposition of medications. Examples of procedures addressing the disposition of medications include timely identification and removal from current medication supply of medications for disposition. Identification of storage method for medications awaiting final disposition. Control and accountability of medications awaiting final disposition consistent with standards of practice. Documentation of actual disposition of medications to include resident name, medication name, strength, prescription number as applicable, quantity, date of disposition, and involved facility staff, consultantess or other applicable individuals, and method of disposition including controlled medications should prevent diversion and or accidental exposure and is consistent with applicable state and federal requirements, local ordinances, and standards of practice. Authorized personnel. The facility may permit unlicensed personnel to administer medications if state law permits, but only under the general supervision of a licensed nurse. The facility assures that all persons administering medications are authorized according to state and federal requirements, oriented to the facility's medication-related procedures, and have access to current information regarding medications being used by the residents, including side effects of medications, contraindications, doses, etc. Examples of procedures addressing authorized personnel include how the facility assures ongoing competency of all staff including temporary, agency, or on-call staff authorized to administer medications and biologicals. Training regarding the operation, limitations, monitoring, and precautions associated with medication administration devices or other equipment, if used, such as Roman IV pumps or other Roman IV delivery systems, including calculating dosage, infusion rates, and compatibility of medications to be added to the Roman IV or enteral feeding pump. Blood glucose meters, including calibration and cleaning between individual residents, and using, maintaining, cleaning, and disposing of the various types of devices for administration including nebulizers, inhalers, syringes, medication cups, spoons, and pill crushers. Identifying pharmacy personnel in addition to the pharmacist, e.g., pharmacy technicians, pharmacist assistants who are authorized under state and federal requirements to access medications and biologicals. C. Services of a licensed pharmacist. The facility is responsible for employing or contracting for the services of a pharmacist to provide consultation on all aspects of pharmaceutical services. The facility may provide for this service through any of several methods in accordance with state requirements such as direct employment or contractual agreement with a pharmacist. Whatever the arrangement or method employed, the facility and the pharmacist identify how they will collaborate for effective consultation regarding pharmaceutical services. The pharmacist reviews and evaluates the pharmaceutical services by helping the facility identify, evaluate, and address medication issues that may affect resident care, medical care, and quality of life. The pharmacist is responsible for helping the facility obtain and maintain timely and appropriate pharmaceutical services that support residents' healthcare needs, goals, and quality of life that are consistent with current standards of practice, and that meet state and federal requirements. This should include, but is not limited to, collaborating with the facility and medical director to develop, implement, evaluate, and revise as necessary the procedures for the provision of all aspects of pharmaceutical services, including procedures to support resident quality of life, such as those that support safe, individualized medication administration programs. Coordinate pharmaceutical services if and when multiple pharmaceutical service providers are utilized, e.g., pharmacy, infusion, hospice, prescription drug plans, PDP. Develop intravenous Roman IV therapy procedures if used within the facility consistent with state requirements, which may include determining competency of staff and facility-based Roman IV admixture procedures that address sterile compounding, dosage calculations, Roman IV pump use, and flushing procedures. Determine in accordance with, or as permitted by state law, the contents of the emergency supply of medications, and monitor the use, replacement, and disposition of the supply. Develop mechanisms for communicating, addressing, and resolving issues related to pharmaceutical services. Strive to assure that medications are requested, received, and administered in a timely manner as ordered by the authorized prescriber in accordance with state requirements, including physicians, advanced practice nurses, pharmacists, and physician assistants. Provide feedback about performance and practices related to medication administration and medication errors. In addition, the pharmacist may collaborate with the facility and medical director on other aspects of pharmaceutical services, including, but not limited to, developing procedures and guidance regarding when to contact a prescriber about a medication issue and or adverse effects, including what information to gather before contacting the prescriber. Developing the process for receiving, transcribing, and recapitulating medication orders. Recommending the types of medication delivery systems to standardize packaging, such as bottles, bubble packs, tear strips, in an effort to minimize medication errors. Developing and implementing procedures regarding automated medication delivery devices or cabinets, if automated devices or cabinets are used, including the types or categories of medications, amounts stored, location of supply, personnel authorized to access the supply, record keeping, monitoring for expiration dates, method to ensure accurate removal of medications, and the steps for replacing the supply when dosages are used, and monitoring the availability of medications within the system. Interacting with the Quality Assessment and Assurance Committee to develop procedures and evaluate pharmaceutical services, including delivery and storage systems within the various locations of the facility in order to prevent, to the degree possible, loss or tampering with the medication supplies. And to define and monitor corrective actions for problems related to pharmaceutical services and medications, including medication errors, recommending current resources to help staff identify medications and information on contraindications, side effects and or adverse effects, dosage levels, and other pertinent information. And identifying facility educational and informational needs about medications, and providing information from sources such as nationally recognized organizations to the facility staff, practitioners, residents, and families. Note, this does not imply that the pharmacist must personally present educational programs. D. Controlled medications. Regulations require that the facility have a system to account for controlled medications receipt and disposition in sufficient detail to enable an accurate reconciliation, and that the facility conduct a periodic reconciliation. This system should include but is not limited to. Record of receipt of all controlled medications with sufficient detail to allow reconciliation, e.g., specifying the name and strength of the medication, the quantity and date received, and the resident's name. However, in some delivery systems, e.g., single-unit package medication delivery system or automated dispensing systems utilizing single-unit packages of medications that are not dispensed pursuant to a specific order, the resident's name may not be applicable. Note, if permitted by, and in accordance with, state requirements, the facility may store some controlled medications in an emergency medication supply. The facility's policies and procedures must address the reconciliation of this supply. See 42 CFR. Section 483.4 5B2 and 3. Records of personnel access, usage, and disposition of all controlled medications with sufficient detail to allow reconciliation, e.g., the MAR, proof of use sheets, or declining inventory sheets, including destruction, wastage, return to the pharmacy/manufacturer, or disposal in accordance with applicable state requirements. Periodic reconciliation of records of receipt, disposition, usage, and inventory for all controlled medications as defined by facility procedures, or when loss is identified. The reconciliation identifies loss or potential diversion of controlled medications so as to minimize the time between the actual loss or potential diversion and the time of detection and follow-up to determine the extent of loss. Because diversion can occur at any time, periodic reconciliation should accommodate actual facility experience, such that if there is any evidence or even suspicion that diversion may be occurring, then that may dictate conducting the periodic reconciliation as frequently as daily. State or other federal requirements may specify the frequency of reconciliation. If discrepancies are identified during the reconciliation, the pharmacist and the facility develop and implement recommendations for resolving them and make referrals to law enforcement agencies as appropriate. Data from injectable, scheduled drug tracking should be regularly reviewed, and discrepancies or unusual access patterns are investigated, including whether residents should be screened for exposure to blood-borne pathogens. See Section 483.80 Infection Control, F755. Liquid-controlled medications are often dispensed in multi-dose containers, which indicate approximate volume. The containers may also be opaque to protect the medication from light. It should be noted that absolute accuracy in tracking volume and use of liquid-controlled medications may not be possible. The actual volume in these containers may be slightly over or under the manufacturer's stated volume, depending on the shape and material of the container and the formulation of the medication, such as thick liquid suspensions. The opaque container, measurement markings, manufacturer fill volume variation, and method for recording usage all make detection of diversion for liquid-controlled medications more difficult. The general standard of practice for documenting usage of liquid-controlled medications is to record the starting volume from the label, record each dose administered, subtract the dose administered from the previously recorded volume, and record the remaining amount. Any observed discrepancy between the recorded amount and what appears to be remaining in the container should be reported according to facility policy. Manufacturer's instructions may list the estimated volume variance, e.g., 30 ml plus or minus 2.5 ml. For liquid-controlled medications, signs of diversion may include an observable discrepancy between the written balances of remaining medication compared to the remaining amount in the bottle upon visual inspection, changes in the viscosity or color of the medication, reports of spills, and, as with other controlled medications, statements from a resident that the medication is not working. Disposal methods for controlled medications must involve a secure and safe method to prevent diversion and or accidental exposure. Fentanyl transdermal patches present a unique situation given the multiple boxed warnings, and the substantial amount of fentanyl remaining in the patch after removal, creating a potential for abuse, misuse, diversion, or accidental exposure. Due to the life-threatening risks associated with exposure to or ingestion of the patch, the Food and Drug Administration, FDA, and manufacturer instructions recommend consumers dispose of used fentanyl patches by folding the patch in half with the sticky sides together and flushing the patch down the sink or toilet. https://dalimedenlemnigov/dalimed/FDA/FDA drug XSLCFM set it equals E15A7E9B 802,549 DD9 A6D BAFC 1959 F and type equals display. The Environmental Protection Agency bans flushing of pharmaceuticals if they are considered hazardous waste pharmaceuticals. Fentanyl patches are not in this category. https://www.epigov/hw/defining hazardous waste listed characteristic and mixed radiological wastes #PANDU. However, this method of disposal may not always be appropriate in nursing homes, particularly in areas where state or local laws restrict flushing of pharmaceuticals. Therefore, nursing homes may use drug disposal products or systems for fentanyl patches and other controlled medications, as long as the facility can show that the product or system minimizes accidental exposure or diversion. Disposal in common areas or resident room trash cans or sharps containers are methods that would not prevent accidental exposure or diversion. Concerns related to fentanyl patch disposal, which could lead to accidental exposure, should be investigated at F689. Note, the pharmacist is not required by these regulations to perform the reconciliation of medications, but rather to evaluate and determine that the facility maintains an accurate account of all controlled medications and completes the reconciliation according to its procedures, consistent with state and federal requirements. Procedures, Section 483.45. Use the medication administration observation and the medication storage and labeling critical element pathway, as appropriate, along with the above interpretive guidelines when determining if the facility meets the requirements for or investigating concerns related to the provision of pharmacy services. Key elements of noncompliance. To cite deficient practice at F755, the surveyor's investigation will generally show that the facility failed to provide medications and or biologicals as ordered by the prescriber to meet the needs of each resident, or ensure that only appropriate personnel administer medications consistent with applicable state law and regulations, or provide pharmaceutical services to meet each resident's needs, which includes acquiring, receiving, dispensing, accurately administering, or disposing of medications, or provide or arrange for a licensed pharmacist who consults on all aspects of pharmaceutical services, or establish systems to accurately reconcile controlled medications using acceptable standards of practice, or have safeguards and systems in place to control, account for, and periodically reconcile controlled medications in order to prevent loss, diversion, or accidental exposure. Deficiency categorization. In addition to actual or potential physical harm, always consider whether psychosocial harm has occurred when determining severity level. For additional guidance, see also the Psychosocial Outcome Severity Guide at the CMS Nursing Home Survey Resources website that can be accessed by visiting https://www.cms.gov/files/zip/survey resources 10,262,022 zip. Examples of noncompliance that demonstrate severity at level 4 may include, but are not limited to: the facility, in collaboration with the pharmacist, failed to establish effective procedures to meet the needs of the residents, such as assuring that pain medications were available to meet the needs of the resident. The facility failed to obtain the routine, regularly scheduled pain medicine for a resident who was to receive it every 6 hours. The investigation confirmed that the resident had been without pain medication for 2 days, the equivalent of 8 missed doses. This failure resulted in the resident complaining of excruciating, unrelieved pain, e.g., a pain score of 9 on a 10-point scale. The pain was all-consuming and overwhelming, leading to sleep loss and a loss in interest and ability to perform activities of daily living. Assuring that devices used to administer medications, such as Roman 4 pumps, were working properly, leading to an adverse consequence at the immediate jeopardy level, in which a resident received an incorrect dose of Roman 4 medication. Provisions to assure that staff were trained or competent to use new medication-related devices, e.g., intravenous pump. This resulted in a resident receiving an inappropriate dose of medication, requiring subsequent hospitalization. Examples of Level 3, actual harm physical or psychosocial that are not immediate jeopardy, may include, but are not limited to: the facility and the pharmacist failed to assure that procedures were developed and implemented so that all medication orders were processed consistently and accurately through the stages of ordering, receiving, and administering. Medications including transfer orders, admission orders, telephone orders, order renewals, and the MAR. For example, an ordering error led to an incorrect dose of a medication being administered, and the resident experienced spontaneous bruising and frequent nosebleeds requiring medical intervention that was able to be performed in the nursing home. The facility failed to implement a system to consistently and accurately reconcile controlled medications. As a result, when staff attempted to administer pain medication to a resident, staff found no available medications despite documentation, which showed the medications were available. The resident experienced mild to moderate pain that prevented the resident from attending physical therapy. Examples of Level 2: no actual harm with a potential for more than minimal harm that is not immediate jeopardy, may include, but are not limited to: as a result of failure of licensed staff to supervise medication administration by authorized unlicensed personnel, 2 residents received their oral antibiotics late on one day. However, the residents did not experience any harm. The facility failed to obtain or provide the services of a pharmacist or to collaborate with the pharmacist to assure that effective policies and procedures were established and implemented, including, for example, a resident did not receive medication for heartburn for 2 or more days and had difficulty sleeping during that time due to nocturnal heartburn. The level of discomfort did not interfere with the residents participating in activities or performing activities of daily living. As a result of failure to identify medications that should not be crushed for administration, a resident received a newly ordered medication that was crushed, contrary to the manufacturer's specifications. While the resident did not experience any harm, the potential for harm to the resident was present. Severity Level 1: no actual harm with potential for minimal harm. Severity Level 1 does not apply for this regulatory requirement because the failure of the facility to provide routine and emergency drugs and biologicals to its residents creates the potential for more than minimal harm. This provision, along with pharmaceutical procedures and services, are essential aspects of both process and outcome requirements. Potential tags for additional investigation. Examples of some of the related requirements that should be considered when concerns have been identified include the following: Section 42, CFR Section 483.12, F602, right to be free from misappropriation/exploitation. Determine if the facility diverted a resident's medication, including, but not limited to, controlled substances for staff use or personal gain. If it is determined that a resident's medications were diverted, the state agency must make referrals to appropriate agencies, such as local law enforcement, Drug Enforcement Administration, State Board of Nursing, State Board of Pharmacy, the State Medicaid Fraud Control Unit, and possibly the State Licensure Board for Nursing Home Administrators. Section 42, CFR Section 483.35, F725, Sufficient Staff, and F726, Competent Staff determine if the facility had competent staff in sufficient numbers available to provide medications on a 24-hour basis to meet the needs of the residents, based upon the comprehensive assessment and care plan. Section 42, CFR Section 483.4, 5G and H, F761, Labeling and storage of drugs and biologicals determine if the facility properly labeled and stored all drugs and biological in accordance with currently accepted professional principles. Section 42, CFR Section 483.70G, F841, Medical Director determine whether the medical director, in collaboration with the facility and the pharmacist, and based on current standards of practice, help the facility develop procedures for the safe and accurate provision of medications to meet the needs of the residents. Section 42, CFR Section 483.70H, F842, Medical records determine whether the facility has maintained clinical records, including medication administration, in accordance with accepted professional standards and practices that are complete, accurately documented, and readily accessible. Section 42, CFR Section 483.7, 5G, F867, Quality Assessment and Assurance if concerns regarding pharmaceutical services have been identified. Determine whether the Quality Assessment and Assurance Committee has identified and responded to those concerns as appropriate and has developed, implemented, and monitored appropriate plans of action to correct identified quality deficiencies. Tag F756. Section 483.4, 5C Drug Regimen Review. Section 483.45C1. The drug regimen of each resident must be reviewed at least once a month by a licensed pharmacist. Section 483.4, 5C2. This review must include a review of the resident's medical chart. Section 483.4, 5C4. The pharmacist must report any irregularities to the attending physician and the facility's medical director and director of nursing, and these reports must be acted upon. Irregularities include, but are not limited to, any drug that meets the criteria set forth in paragraph D of this section for an unnecessary drug. Roman II, any irregularities noted by the pharmacist during this review must be documented on a separate written report that is sent to the attending physician and the facility's medical director and director of nursing and lists, at a minimum, the resident's name, the relevant drug, and the irregularity the pharmacist identified. Roman III, the attending physician must document in the resident's medical record that the identified irregularity has been reviewed and what, if any, action has been taken to address it. If there is to be no change in the medication, the attending physician should document his or her rationale in the resident's medical record. Section 483.4, 5C5, the facility must develop and maintain policies and procedures for the monthly drug regimen review that include, but are not limited to, time frames for the different steps in the process and steps the pharmacist must take when he or she identifies an irregularity that requires urgent action to protect the resident. Intent Section 483.4, 5C1, 2, 4, and 5. The intent of this requirement is that the facility maintains the resident's highest practicable level of physical, mental, and psychosocial well-being, and prevents or minimizes adverse consequences related to medication therapy to the extent possible, by providing oversight by a licensed pharmacist, attending physician, medical director, and the director of nursing (DON). Note, although the regulatory language refers to drug regimen review, the guidance in this document generally will refer to medication regimen review, except in those situations where the term drug has become part of an established pharmaceutical term, e.g., adverse drug event and adverse drug reaction or consequence. Definitions section 483.4, 5C1, 2, 4, and 5. Definitions are provided to clarify terminology related to pharmaceutical services and the management of each resident's medication regimen for effectiveness and safety. Adverse consequence is a broad term referring to unwanted, uncomfortable, or dangerous effects that a drug may have, such as impairment or decline in an individual's mental or physical condition, or functional or psychosocial status. It may include various types of adverse drug reactions and interactions, e.g., medication, medication food, and medication disease, adapted from the Merck Manual Professional. Version http://www.merckmanuals.com/professional/clinical pharmacology/adverse drug reactions/adverse drug reactions. Note: adverse drug reaction (ADR) is a form of adverse consequence. It may be either a secondary effect of a medication that is usually undesirable and different from the therapeutic and helpful effects of the medication, or any response to a medication that is noxious and unintended and occurs in doses used for prophylaxis, diagnosis, or therapy. The term side effect is often used interchangeably with ADR. However, side effects are but one of 5 ADR categories. The others are hypersensitivity, idiosyncratic response, toxic reactions, and adverse medication interactions. A side effect is an expected, well-known reaction that occurs with a predictable frequency and may or may not rise to the level of being an adverse consequence. Clinically significant means effects, results, or consequences that materially affect or are likely to affect an individual's mental, physical, or psychosocial well-being either positively by preventing, stabilizing, or improving a condition or reducing a risk, or negatively by exacerbating, causing, or contributing to a symptom, illness, or decline in status. Dose is the total amount/strength/concentration of a medication given at one time or over a period of time. The individual dose is the amount/strength/concentration received at each administration. The amount received over a 24-hour period may be referred to as the daily dose. Irregularity refers to use of medication that is inconsistent with accepted standards of practice for providing pharmaceutical services, not supported by medical evidence, and or that impedes or interferes with achieving the intended outcomes of pharmaceutical services. An irregularity also includes, but is not limited to, use of medications without adequate indication, without adequate monitoring, in excessive doses, and or in the presence of adverse consequences, as well as the identification of conditions that may warrant initiation of medication therapy. See reference to F757, Unnecessary Drugs, which defines unnecessary drugs in opening regulatory language. Medication interaction is the impact of another substance such as another medication, herbal product, food, or substances used in diagnostic studies upon a medication. The interactions may alter absorption, distribution, metabolism, or elimination. These interactions may decrease the effectiveness of the medication or increase the potential for adverse consequences. Medication Regimen Review (MRR), or Drug Regimen Review, is a thorough evaluation of the medication regimen of a resident, with the goal of promoting positive outcomes and minimizing adverse consequences and potential risks associated with medication. The MRR includes review of the medical record in order to prevent, identify, report, and resolve medication-related problems, medication errors, or other irregularities. The MRR also involves collaborating with other members of the IDT, including the resident, their family, and or resident representative. Guidance section 483.45 C1, 2, 4, and 5. A. Overview. many nursing home residents have been identified as being at high risk for adverse consequences related to medications. Some adverse consequences may mimic symptoms of chronic conditions, the aging process, or a newly emerging condition. This guidance is not intended to imply that all adverse consequences related to medications are preventable, but rather to specify that a system exists to assure that medication usage is evaluated on an ongoing basis, that risks and problems are identified and acted upon, and that medication-related problems must be considered when the resident has a change in condition. This guidance will discuss the following aspects of the facility's MRR component of the pharmaceutical services systems: a pharmacist's review of the resident's medication regimen and medical record to identify and report irregularities, and acting upon identified irregularities in order to minimize or prevent adverse consequences to the extent possible. Note, the surveyor's review of medication use is not intended to constitute the practice of medicine. However, surveyors are expected to investigate the basis for decisions and interventions affecting residents, including whether or not the resident's family and/or representative were informed about risks, benefits, and treatment options, and involved in the decision-making process. The review should take into account resident preferences and provide recommendations that assist facility staff in understanding and communicating to the resident any risks related to their preferences regarding medications or medication administration, as well as modifications that can be made to mitigate those risks. Transitions in care, such as a move from home or hospital to the nursing home, or vice versa, increase the risk of medication-related issues. Medications may be added, discontinued, omitted, or changed. It is important, therefore, to review the medications. Currently, safeguards to help identify medication issues around transitions in care and throughout a resident's stay include the pharmacist performing the medication regimen review, which includes a review of the resident's medical record, at least monthly. The pharmacist reporting any irregularities in a separate written report to the attending physician, medical director, and director of nursing, and the attending physician reviewing and acting on any identified irregularities. B. Medication regimen review MRR. The MRR is an important component of the overall management and monitoring of a resident's medication regimen. The pharmacist must review each resident's medication regimen at least once a month in order to identify irregularities and to identify clinically significant risks and/or actual or potential adverse consequences which may result from or be associated with medications. It may be necessary for the pharmacist to conduct the MRR more frequently, for example weekly, depending on the resident's condition and the risks for adverse consequences related to current medications. Regulations prohibit the pharmacist from delegating the medication regimen reviews to other staff. The requirement for the MRR applies to all residents, whether short or long stay, without exceptions. The pharmacist performing the monthly MRR must also review the resident's medical record to appropriately monitor the medication regimen and ensure that the medications each resident receives are clinically indicated. Certain circumstances, which may include residents who have multiple medical conditions, concurrent administration of certain medications, administration of medications which require close monitoring through lab work, and transitions of care may also increase the risk of adverse consequences. Review of the medical record as part of the MRR may prevent errors due to drug-drug interactions, omissions, duplication of therapy, or miscommunication during the transition from one team of care providers to another. Facilities must develop policies and procedures to address the MRR. The policies and procedures must specifically address the appropriate time frames for the different steps in the MRR process, and the steps a pharmacist must follow when he or she identifies an irregularity that requires immediate action to protect the resident and prevent the occurrence of an adverse drug event. MRR policies and procedures should also address, but not be limited to, MRRs for residents who are anticipated to stay less than 30 days, MRRs for residents who experience an acute change of condition and for whom an immediate MRR is requested after appropriate staff have notified the resident's physician, the medical director, and the director of nursing about the acute change. While conducting the MRR in the facility is not required for compliance, important information about indications for use, actual or potential medication irregularities, or adverse consequences such as symptoms of tardive dyskinesia, dizziness, anorexia, or falls may be attainable only by talking to the staff, reviewing the medical record, and observing and speaking with the resident's family and/or representative. However, electronic health and medication records and other available technology may permit the pharmacist to conduct some components of the review outside the facility. Electronic transmission of information may enable facilities to quickly communicate resident-specific information to an off-site pharmacy or pharmacist. However, electronic communication must remain secure to protect individually identifiable information, as mandated by the Health Insurance Portability and Accountability Act, HIPAA of 1996. With secure electronic communication, the pharmacist may promptly identify actual or potential medication-related problems before a medication is initiated or soon afterwards. However, brief communication via secure devices to address or prevent immediate or potential problems does not constitute a complete MRR. All information that is needed to perform an MRR may not be available electronically. For example, flow sheets that monitor a resident's pain or that document other observations or symptoms. Resources are available to facilitate evaluating medication concerns related to the performance of the MRR, such as U.S. Department of Health and Human Services, Food and Drug Administration, FDA http://www.fda.gov/medwatch/safetyhtm. American Society of Consultant Pharmacists, ASCP http://askcom/ American Medical Directors Association, the Society for Post-Acute and Long-Term Care Medicine, AMDA http://www.paltcorg/ National Coordinating Council for Medication Error Reporting and Prevention. NCCMERP http://www.nccmerp.org. American Geriatrics Society AGS http://www.americangeriatrics.org. And note, references to non-CMS sources or sites on the Internet are provided as a service and do not constitute or imply endorsement of these organizations or their programs by CMS or the U.S. Department of Health and Human Services. CMS is not responsible for the content of pages found at these sites. URL addresses were current as of the date of this publication. Identification of irregularities. An objective of the MRR is to try to minimize or prevent adverse consequences by identifying irregularities including, for example, syndromes potentially related to medication therapy, emerging or existing adverse medication consequences, e.g., drug reactions or medication errors. The resident's record may contain information regarding possible and/or actual medication irregularities. Possible sources to obtain this information include the Medication Administration Records MAR, prescriber's orders, progress, nursing and consultant's notes, the Resident Assessment Instrument RAI, laboratory and diagnostic test results, and other sources of information about documented expressions or indications of distress and/or changes in condition. The pharmacist may also obtain information from the quality measures/quality indicator reports, the attending physician, facility staff, and as appropriate from interviewing, assessing, and/or observing the resident. The pharmacist's review considers factors such as Whether the physician and staff have documented objective findings, diagnoses, symptoms, and / or resident goals and preferences to support indications for use. Whether the physician and staff have identified and acted upon, or should be notified about, the resident's allergies and / or potential side effects and significant medication interactions. Whether the medication dose, frequency, route of administration, and duration are consistent with the resident's condition, manufacturer's recommendations, and applicable standards of practice. Whether the physician and staff have documented progress towards, decline from, or maintenance of the resident's goal for the medication therapy. Whether the physician and staff have documented any attempts for gradual dose reduction GDR or added any non-pharmacological approaches in an effort to reduce or discontinue a drug. Whether the physician and staff have obtained and acted upon laboratory results, diagnostic studies, or other measurements such as bowel function, intake, and output as applicable. Whether medication errors exist or circumstances exist that make them likely to occur, and whether the physician and staff have noted and acted upon possible medication-related causes of recent or persistent changes in the resident's condition, such as worsening of an existing problem or the emergence of new signs or symptoms. Some examples of changes potentially related to medication use that could occur include anorexia and / or unplanned weight loss or weight gain, expressions or indications of distress or other changes in a residence, psychosocial status, bowel function changes including constipation, ileus impaction, confusion, cognitive decline, worsening of dementia including delirium, dehydration, fluid / electrolyte imbalance, excessive sedation, insomnia or sleep disturbance, falls, dizziness, or evidence of impaired coordination, headaches, muscle pain, generalized aching or pain, rash, pruritus, spontaneous or unexplained bleeding, bruising, and urinary retention or incontinence. Upon conducting the MRR, the pharmacist may identify and report irregularities in one or more of the following categories. The use of a medication without identifiable evidence of adequate indications for use, such as the use of a medication to treat a clinical condition without identifiable evidence that safer alternatives or more clinically appropriate medications have been considered. The use of homeopathic or herbal options, e.g., St. John's wort that may interfere with the effectiveness of clinically appropriate medications. The use of an appropriate medication that is not helping attain the intended treatment or resident's goals because of timing of administration, dosing intervals, sufficiency of dose, techniques of administration, or other reasons. The use of a medication in an excessive dose including duplicate therapy or for excessive duration, thereby placing the resident at greater risk for adverse consequences or causing existing adverse consequences. The presence of an adverse consequence associated with the resident's current medication regimen. The use of a medication without evidence of adequate monitoring, i.e., either inadequate monitoring of the response to a medication or an inadequate response to the findings. Presence of medication errors or the risk for such errors. Presence of a clinical condition that might warrant initiation of medication. Therapy and note, the presence of a diagnosis or symptom does not necessarily warrant medication, but often depends on the consideration of many factors simultaneously. A medication interaction associated with the current medication regimen. Note, concomitant use of certain medication combinations is not necessarily inappropriate. Often, several medications with documented interactions can be given together safely. However, concomitant use of certain medications warrants careful consideration of potential alternatives, possible need to modify doses, and diligent monitoring. Websites for organizations such as AMDA, the Society for Post-Acute and Long-Term Care Medicine American Medical Directors Association, have made information available regarding problematic medication interactions in the long-term care population. https://www.amdcom/tools/clinical/m3/topncfm and https://www.crediblmzorg/healthcareproviders/drug-drug interaction. Woosley, Rel, and Romero, Ka www.crediblmzorg QT Drugs List, accessed March 6, 2017, Azert, Inc. 1822 Innovation Park Dr. Oro Valley, as 85755. Note: references to non-CMS sources do not constitute or imply endorsement of these organizations or their programs by CMS or the U.S. Department of Health and Human Services and were current as of the date of this publication. Location and notification of medication regimen review findings. The pharmacist is expected to document either that no irregularity was identified or the nature of any identified irregularities. The pharmacist is responsible for reporting any identified irregularities to the attending physician, the facility's medical director, and director of nursing. The timeliness of notification of irregularities depends on factors including the potential for or presence of serious adverse consequences. For example, immediate notification is indicated in cases of bleeding in a resident who is receiving anticoagulants or in cases of possible allergic reactions to antibiotic therapy. The pharmacist must document any identified irregularities in a separate written report. The report may be in paper or electronic form. If no irregularities were identified during the review, the pharmacist includes a signed and dated statement to that effect. The pharmacist does not need to document a continuing irregularity in the report each month if the attending physician has documented a valid clinical rationale for rejecting the pharmacist's recommendation, unless warranted by a change in the resident's condition or other circumstances. The pharmacist's findings are considered part of each resident's medical record and as such are available to the resident/representative upon request. If documentation of the findings is not in the active record, it is maintained within the facility and is readily available for review. Establishing a consistent location for the pharmacist's findings and recommendations can facilitate communication with the attending physician, the director of nursing, the remainder of the IDT, the medical director, the resident and his or her legal representative, the ombudsman and surveyors. Response to irregularities identified in the MRR. The medical record must show documentation that the attending physician reviewed any irregularities identified by the pharmacist. For those issues that require physician intervention, the attending physician either accepts and acts upon the report and recommendations or rejects all or some of the report, and should document his or her rationale of why the recommendation is rejected in the resident's medical record. It is not acceptable for an attending physician to document only that he/she disagrees with the report, without providing some clinical basis for disagreeing. The facility should have a procedure for how to resolve situations where the attending physician does not concur with or take action on identified irregularities, and the attending physician is also the medical director. Key elements of noncompliance. To cite deficient practice at F756, the surveyor's investigation will generally show that the MRR was not conducted by a licensed pharmacist, or the pharmacist failed to conduct a complete MRR, at least monthly or more. Frequently, as indicated by the resident's condition for every resident of the facility, or the pharmacist's findings in the MRR did not show evidence that the pharmacist also reviewed the resident's chart. For example, the pharmacist did not reference the resident response to a particular medication that was cited as an irregularity, or the pharmacist failed to identify or report the absence of or inadequate indications for use of a medication, or a medication or medication combination with significant potential for adverse consequences or medication interactions. Or the pharmacist failed to identify and slash or report medications prescribed or administered in excessive dose, including, but not limited to, duplicate therapy. Or the pharmacist failed to identify and slash or report medications prescribed or administered for excessive duration. Or the pharmacist failed to identify and slash or report medications prescribed or administered without adequate monitoring. Or the pharmacist failed to identify or report medications in a resident's regimen that could, as of the review date, be causing or associated with new, worsening, or progressive signs and symptoms. Or the pharmacist failed to identify and report the absence of any explanation as to why or how the benefit of a medication S with potential for clinically significant adverse consequences outweighs the risk. Or the attending physician failed to document that he or she reviewed the pharmacist's identified irregularities and slash or failed to document the action taken or not taken to address the irregularities. Or the facility failed to develop, maintain, and implement policies and procedures which address the time frames for the steps in the MRR process. Or the facility failed to develop and implement policies and procedures which address steps the pharmacist must take when he or she identifies an irregularity that requires urgent action to protect the resident. Procedure: use the unnecessary medications, psychotropic medications, and medication regimen review critical element pathway, as appropriate, along with the above interpretive guidelines when determining if the facility meets the requirements for or investigating concerns related to medication regimen review. Deficiency categorization. In addition to actual or potential physical harm, always consider whether psychosocial harm has occurred when determining severity level. See Appendix P, Section Roman 4, E, Psychosocial Outcome Severity Guide. Examples of noncompliance that demonstrate severity at Level 4 include, but are not limited to: despite identifying irregularities with the potential for serious harm or death in a resident's medication regimen, the pharmacist did not report the irregularities to the attending physician, DON, and medical director, or action was not taken on the irregularities reported. On the MRR, the pharmacist identified that a resident was prescribed an antipsychotic medication without a clinical indication. This placed the resident at likely risk for harm, such as experiencing a fall, mental status changes, or sustained negative psychosocial outcomes. The medical record did not show evidence that the attending physician had reviewed and responded to the identified irregularity. Examples of Level 3, actual harm physical or psychosocial that are not immediate jeopardy, include, but are not limited to: the pharmacist's MRR failed to identify the indication for continued use for opioid analgesics that had been prescribed for a resident's acute pain which had resolved. As a result of prolonged duration of use, the resident continued to be or became more lethargic and slash or withdrawn. The pharmacist's MRR identified that the staff were crushing medications that should not be crushed. As a result of facility failure to act upon the notification, the resident experienced clinically significant adverse consequences such as hypoglycemia or hypotension that required medical intervention. The attending physician failed to act in response to the pharmacist's MRR, which identified the indefinite continuation of an antidepressant in a resident who had no history of depression, who had been placed on the antidepressant without an evaluation to confirm presence of depression, and whose function and mood were not monitored while getting the medication for months. The resident experienced clinically significant adverse consequences, such as falls without serious injury, constipation, or change in weight. Examples of Level 2, no actual harm with a potential for more than minimal harm that is not immediate jeopardy, may include but are not limited to: the facility failed to respond to the pharmacist's notification that the resident was not receiving an over-the-counter dietary supplement that had been prescribed. Currently, There was no change in the resident's condition, such as a weight loss. The pharmacist's MRR failed to evaluate and report on the potential adverse consequences of a medication that may increase the possible side effects of another clinically appropriate medication that had been prescribed. The resident had not yet experienced side effects from the combined medications. Severity Level 1 considerations: no actual harm with potential for minimal harm. Severity Level 1 does not apply for this regulatory requirement because the failure to perform the MRR according to the regulatory provisions creates the potential for more than minimal harm. Potential tags for additional investigation. Examples of some of the related requirements that should be considered when concerns have been identified include the following. Section 42, CFR Section 483.10G14, F755. Notification of changes or review whether a member of the IDT contacted the attending physician regarding a significant change in the resident's condition in relation to a potential adverse consequence of a medication, or a need to alter treatment significantly, i.e., a need to discontinue an existing form of treatment due to adverse consequences, or to commence a different form of treatment. Section 42, CFR Section 483.45D, F757, unnecessary drugs, and 42 CFR Section 483.45E, F758, psychotropic medications. Review whether the resident is receiving any medications without an indication for use, in excessive dose or duration, with inadequate monitoring, or in the presence of any adverse consequences that indicate that the dose should be reduced or discontinued. Section 42, CFR Section 483.30A, F710, physician supervision. Review whether the attending physician supervised the resident's medical treatment, including assessing the resident's condition, identifying the need for and continuing use of medication to address the resident's needs, and identifying and addressing adverse consequences related to medications. Section 42, CFR Section 483.30B, F711 physician visits, and 42 CFR Section 483.30C, F712. Frequency of physician visits. Review whether the attending physician or another designated practitioner reviewed the resident's total program of care, including the beneficial and adverse effects of medications and treatment, and provided a relevant progress note at each visit. Section 42, CFR Section 483.45A, B13, F755, pharmacy services. Review whether the licensed pharmacist has provided consultation regarding all aspects of pharmaceutical services. Section 42, CFR Section 483.70G, F841, medical director. Review whether the medical director, when requested by the facility, interacted with the attending physician regarding an inadequate response to identified or reported potential medication irregularities and adverse consequences. Tag F757. Section 483.4, 5D, unnecessary drugs general. Each resident's drug regimen must be free from unnecessary drugs. An unnecessary drug is any drug when used. Section 483.45D1, in excessive dose including duplicate drug therapy, or Section 483.45D2 for excessive duration, or Section 483.45D3 without adequate monitoring, or Section 483.45D4 without adequate indications for its use, or Section 483.45D5 in the presence of adverse consequences which indicate the dose should be reduced or discontinued, or Section 483.45D6, any combinations of the reasons stated in paragraphs D1 through 5 of this section. Tag F758. Section 483.45C3, A psychotropic drug is any drug that affects brain activities associated with mental processes and behavior. These drugs include, but are not limited to, drugs in the following categories: I antipsychotic, Roman 2 antidepressant, Roman 3 anti-anxiety, and Roman 4 hypnotic. Section 483.4 5E Psychotropic drugs. Based on a comprehensive assessment of a resident, the facility must ensure that Section 483.4 5E1 residents who have not used psychotropic drugs are not given these drugs unless the medication is necessary to treat a specific condition as diagnosed and documented in the clinical record. Section 483.4 5E2 residents who use psychotropic drugs receive gradual dose reductions and behavioral interventions unless clinically contraindicated in an effort to discontinue these drugs. Section 483.4 5E3 residents do not receive psychotropic drugs pursuant to a PRN order unless that medication is necessary to treat a diagnosed specific condition that is documented in the clinical record. And Section 483.4 5E4 PRN orders for psychotropic drugs are limited to 14 days. Except as provided in Section 483.4 5E5, if the attending physician or prescribing practitioner believes that it is appropriate for the PRN order to be extended beyond 14 days, he or she should document their rationale in the resident's medical record and indicate the duration for the PRN order. Section 483.4 5E5 PRN orders for antipsychotic drugs are limited to 14 days and cannot be renewed unless the attending physician or prescribing practitioner evaluates the resident for the appropriateness of that medication. Intent. F757 Section 483.4 5D Unnecessary drugs and F758 Section 483.4 5C3 and E-psychotropic drugs. The intent of these requirements is that each resident's entire drug/medication regimen is managed and monitored to promote or maintain the resident's highest practicable mental, physical, and psychosocial well-being. The facility implements gradual dose reductions, GDR, and non-pharmacological interventions, unless contraindicated, prior to initiating or instead of continuing psychotropic medication. And PRN orders for psychotropic medications are only used when the medication is necessary and PRN use is limited. Note, for concerns related to unnecessary medications, excluding psychotropic medications, surveyors should assess compliance with Section 483.45D, F757. For concerns related to psychotropic medications only, including the unnecessary medication requirements, surveyors should assess compliance with Section 483.45C and E, F758. The guidance for these two tags is combined to avoid unnecessary duplication. Although the regulatory language refers to drugs, the guidance in this document generally will refer to medications, except in those situations where the term drug has become part of an established pharmaceutical term, e.g., adverse drug event and adverse drug reaction or consequence. For purposes of this guidance, references to the pharmacist mean the facility's licensed pharmacist, whether employed directly by the facility or through arrangement. The surveyor's review of medication use is not intended to constitute the practice of medicine. However, surveyors are expected to investigate the basis for decisions and interventions affecting residents. Definitions F757 Section 483.45 D. Unnecessary drugs and F758 Section 483.4 5C3 and E. Psychotropic drugs. Definitions are provided to clarify terminology related to medications and to the evaluation and treatment of residents. Adverse consequence is a broad term referring to unwanted, uncomfortable, or dangerous effects that a drug may have, such as impairment or decline in an individual's mental or physical condition, or functional or psychosocial status. It may include various types of adverse drug reactions and interactions, e.g., medication, medication food, and medication disease, adapted from the Merck Manual Professional Version, http://www.merckmanuals.com/professional/clinical pharmacology/adverse drug reactions/adverse drug reactions. Note: adverse drug reaction, ADR, is a form of adverse consequences. It may be either a secondary effect of a medication that is usually undesirable and different from the therapeutic effect of the medication, or any response to a medication that is noxious and unintended and occurs in doses for prophylaxis, diagnosis, or treatment. The term side effect is often used interchangeably with ADR. However, side effects are but one of 5 ADR categories, the others being hypersensitivity, idiosyncratic response, toxic reactions, and adverse medication interactions. A side effect is an expected, well-known reaction that occurs with a predictable frequency and may or may not constitute an adverse consequence. Anticholinergic side effect is an effect of a medication that opposes or inhibits the activity of the parasympathetic cholinergic nervous system to the point of causing symptoms such as dry mouth, blurred vision, tachycardia, urinary retention, constipation, confusion, delirium, hallucinations, flushing, and increased blood pressure. Types of medications that may produce anticholinergic side effects include antihistamines, antidepressants, antipsychotics, antiemetics, muscle relaxants, and certain medications used to treat cardiovascular conditions, Parkinson's disease, urinary incontinence, gastrointestinal issues, and vertigo. Behavioral interventions are individualized, non-pharmacological approaches to care that are provided as part of a supportive physical and psychosocial environment, directed toward understanding, preventing, relieving, and or accommodating a resident's distress or loss of abilities, as well as maintaining or improving a resident's mental, physical, or psychosocial well-being. Clinically significant refers to effects, results, or consequences that materially affect or are likely to affect an individual's mental, physical, or psychosocial well-being either positively by preventing, stabilizing, or improving a condition or reducing a risk, or negatively by exacerbating, causing, or contributing to a symptom, illness, or decline in status. Dose is the total amount/strength/concentration of a medication given at one time or over a period of time. The individual dose is the amount/strength/concentration received at each administration. The amount received over a 24-hour period may be referred to as the daily dose. Duplicate therapy refers to multiple medications of the same pharmacological class/category or any medication therapy that substantially duplicates a particular effect of another medication that the individual is taking. Excessive dose means the total amount of any medication, including duplicate therapy, given at one time or over a period of time that is greater than the amount recommended by the manufacturer's label, package insert, and accepted standards of practice for a resident's age and condition. Expressions or indications of distress refers to a person's attempt to communicate unmet needs, discomfort, or thoughts that he or she may not be able to articulate. The expressions may present as crying, apathy, or withdrawal, or as verbal or physical actions such as pacing, cursing, hitting, kicking, pushing, scratching, tearing things, or grabbing others. Extrapyramidal symptoms, EPS, are neurological side effects that can occur at any time from the first few days of treatment with antipsychotic medication to years later. EPS includes various syndromes such as akathisia, which refers to a distressing feeling of internal restlessness that may appear as constant motion, the inability to sit still, fidgeting, pacing, or rocking. Medication-induced Parkinsonism, which refers to a syndrome of Parkinson-like symptoms including tremors, shuffling gait, slowness of movement, expressionless face, drooling, postural unsteadiness, and rigidity of muscles in the limbs, neck, and trunk. Dystonia, which refers to an acute, painful, spastic contraction of muscle groups, commonly the neck, eyes, and trunk, that often occurs soon after initiating treatment and is more common in younger individuals. Gradual dose reduction (GDR) is the stepwise tapering of a dose to determine if symptoms, conditions, or risks can be managed by a lower dose, or if the dose or medication can be discontinued. Indications for use is the identified, documented clinical rationale for administering a medication that is based upon an assessment of the resident's condition and therapeutic goals and is consistent with manufacturers' recommendations and or clinical practice guidelines, clinical standards of practice, medication references. Clinical studies or evidence-based review articles that are published in medical and or pharmacy journals. Neuroleptic malignant syndrome, NMS, is a syndrome related to the use of medications, mainly antipsychotics, that typically presents with a sudden onset of diffuse muscle rigidity, high fever, labile blood pressure, tremor, and notable cognitive dysfunction. It is potentially fatal if not treated immediately, including stopping the offending medications. Psychotropic drug is defined in the regulations at Section 483.45C3 as any drug that affects brain activities associated with mental processes and behavior. Psychotropic drugs include, but are not limited to, the following categories: antipsychotics, antidepressants, anti-anxiety, and hypnotics. Serotonin syndrome is a potentially serious clinical condition resulting from overstimulation of serotonin receptors. It is commonly related to the use of multiple serotonin-stimulating medications, e.g., SRI, SNRI, triptans, certain antibiotics. Symptoms may include restlessness, hallucinations, confusion, loss of coordination, fast heartbeat, rapid changes in blood pressure, increased body temperature, overactive reflexes, nausea, vomiting, and diarrhea. Tardive dyskinesia refers to abnormal, recurrent, involuntary movements that may be irreversible and typically present as lateral movements of the tongue or jaw, tongue thrusting, chewing, frequent blinking, brow arching, grimacing, and lip smacking, although the trunk or other parts of the body may also be affected. Guidance F757 Section 483.4, 5D unnecessary drugs, and F758 Section 483.4, 5C3 and E psychotropic drugs. Medications are an integral part of the care provided to residents of nursing facilities. They are administered to try to achieve various outcomes, such as curing an illness, arresting or slowing a disease process, reducing or eliminating symptoms, or as part of diagnosing or preventing a disease or symptom. Proper medication selection and prescribing, including dose, duration, and type of medication may help stabilize or improve a resident's outcome, quality of life, and functional capacity. Any medication or combination of medications, or the use of a medication without adequate indications, in excessive dose, for an excessive duration, or without adequate monitoring may increase the risk of a broad range of adverse consequences such as medication interactions, depression, confusion, immobility, falls, hip fractures, and death. The Beers criteria for potentially inappropriate medication use in older adults provides information on safely prescribing medications for older adults. http://www.healthimaging.org/medicationsolderadults/. Note: references to non-CMS sources do not constitute or imply endorsement of these organizations or their programs by CMS or the U.S. Department of Health and Human Services and were current as of the date of this publication. Intrinsic factors including physiological changes accompanying the aging process, multiple comorbidities, and certain medical conditions may affect the absorption, distribution, metabolism, or elimination of medications from the body, and may also increase an individual's risk of adverse consequences. While assuring that only those medications required to treat the resident's assessed condition are being used, reducing the need for and maximizing the effectiveness of medications are important considerations for all residents. Therefore, as part of all medication management, especially psychotropic medications, it is important for the IDT to implement non-pharmacological approaches designed to meet the individual needs of each resident. Educating facility staff and providers about the importance of implementing individualized, non-pharmacological approaches to care prior to the use of medications may minimize the need for medications or reduce the dose and duration of those medications. Additional information, as well as examples of non-pharmacological interventions, may be found in other guidance for regulations at F741 Section 483.40, Behavioral Health Services, and F679 Section 483.24, Quality of Life. The indications for initiating, withdrawing, or withholding medication as well as the use of non-pharmacological approaches, are determined by assessing the resident's underlying condition, current signs, symptoms and expressions, and preferences and goals for treatment. This includes, where possible, the identification of the underlying causes, since a diagnosis alone may not warrant treatment with medication. Orders from multiple prescribers or providers can increase the resident's chances of receiving unnecessary medications. Staff and practitioner access to current medication references and pertinent clinical protocols helps to promote safe administration and monitoring of medications. One of the existing mechanisms to warn prescribers about risks associated with medications is the Food and Drug Administration (FDA) requirement that manufacturers include within the medication labeling warnings about adverse reactions and potential safety hazards identified both before and after approval of a medication. And what to do if they occur. Visit https://www.fda.gov/safety/medwatch FDA Safety Information and Adverse Event Reporting Program, or search for FDA Safety Alerts for Human Medical Products. Manufacturers are required to update labels to warn about newly identified safety hazards, regardless of whether causation has been proven, and whether the medication is prescribed for a disease or condition that is not included in the indications and usage section of the labeling so-called off-label or unapproved use. Federal regulations at 21 CFR 201.57A4 and C1 also require manufacturers to place statements about serious problems or contraindications in a prominently displayed box that appears on the medication labeling and in greater detail in the full prescribing information that accompanies the medication. The boxed warning is reserved for prescription drugs that pose a significant risk of serious or life-threatening adverse effects based on medical studies. The facility's pharmacist is a valuable source of information about medications. Listings or descriptions of most significant risks, recommended doses, medication interactions, cautions, etc., can be found in widely available, standard references and computer software and systems that provide up-to-date information. It is important to note that some of the medication information found in many of these references is not specific to older adults or individuals residing in nursing homes. A list of resources and tools is provided at the end of this guidance. Medication management. Medication management is based in the care process and includes recognition or identification of the problem/need, assessment, diagnosis/cause identification, management/treatment, monitoring, and revising interventions, as warranted, as well as documenting medication management steps. The attending physician plays a key leadership role in medication management by developing, monitoring, and modifying the medication regimen in conjunction with residents, their families, and or representative S and other professionals and direct care staff the IT. When selecting medications and non-pharmacological approaches, members of the IDT, including the resident, his or her family, and or representative S, participate in the care process to identify, assess, address, advocate for, monitor, and communicate the resident's needs and changes in condition. This guidance is intended to help the surveyor determine whether the facility's medication management supports and promotes involvement of the resident, his or her family, and or the resident representative in the medication management process. Selection of medications S, based on assessing relative benefits and risks to the individual resident. Evaluation of a resident's physical, behavioral, mental, and psychosocial signs and symptoms in order to identify the underlying cause S, including adverse consequences of medications. Selection and use of medications in doses and for the duration appropriate to each resident's clinical conditions, age, and underlying causes of symptoms, and based on assessing relative benefit and risks to, and preferences and goals of, the individual resident. The use of non-pharmacological approaches, unless contraindicated, to minimize the need for medications, permit use of the lowest possible dose, or allow medications to be discontinued, and the monitoring of medications for efficacy and adverse consequences. Resident choice, if a resident declines treatment, the facility staff and physician should inform the resident about the risks related to the lack of the medication and discuss appropriate alternatives such as offering the medication at another time or in another dosage form, or offer an alternative medication or non-pharmacological approach. Advance directives. A resident's advance directives may include withdrawing or withholding medications. Whether or not a resident has an advance directive, the facility is responsible for giving treatment, support, and other care that is consistent with the resident's condition and applicable care instructions, according to the resident's care plan. If there are concerns regarding resident choice or advance directives, consider investigating the requirements at Section 483.10, Resident Rights, and Section 483.21, Care Planning. The resident's medical record documents and communicates to the entire team the basic elements of the care process and the resident's goals and preferences. Information about aspects of the care process related to medications may be found in various locations within the record, such as hospital discharge summaries and transfer notes, progress notes and interdisciplinary notes, history and physical examination, resident assessment instrument RI, plan of care, laboratory reports, professional consults, medication orders, medication regimen review MRR reports, and medication administration records MAR. The regulations associated with medication management include consideration of indication and clinical need for medication, dose including duplicate therapy, duration, adequate monitoring for efficacy and adverse consequences, and preventing, identifying, and responding to adverse consequences. With regard to psychotropic medications, the regulations additionally require giving psychotropic medications only when necessary to treat a specific diagnosed and documented condition, implementing GDR and other non-pharmacologic interventions for residents who receive psychotropic medications unless contraindicated, and limiting the timeframe for PRN psychotropic medications, which are not antipsychotic medications, to 14 days, unless a longer time frame is deemed appropriate by the attending physician or the prescribing practitioner. Limiting PRN psychotropic medications, which are antipsychotic medications, to 14 days, and not entering a new order without first evaluating the resident. Note, while there may be isolated situations where a pharmacological intervention is required first. These situations do not negate the obligation of the facility to develop and implement non-pharmacological interventions. For additional information related to situations where a non-pharmacological intervention may be contraindicated, refer to Section 483.40A2, Implementing Non-Pharmacological Interventions. Indication for use. The resident's medical record must show documentation of adequate indications for a medication's use and the diagnosed condition for which a medication is prescribed. An evaluation of the resident by the IDT helps to identify his or her needs, goals, comorbid conditions, and prognosis to determine factors including medications and new or worsening medical conditions that are affecting signs, symptoms, and test results. This evaluation process is important when selecting initial medications and or non-pharmacological approaches, and when deciding whether to modify or discontinue a current medication. The evaluation also clarifies whether other causes for the symptoms, including expressions or indications of distress that could mimic a psychiatric disorder, have been ruled out. Whether the physical, mental, behavioral, and or psychosocial signs, symptoms, or related causes are persistent or clinically significant enough, e.g., causing functional decline to warrant the initiation or continuation of medication therapy. Whether non-pharmacological approaches are implemented, unless clinically contraindicated for the resident or declined by the resident. Whether a particular medication is clinically indicated to manage the symptom or condition, and whether the intended or actual benefit is understood by the resident, and, if appropriate, his or her family and or representative S, and is sufficient to justify the potential risk S or adverse consequences associated with the selected medication, dose, and duration. The content and extent of the evaluation may vary with the situation and may employ various assessment instruments and diagnostic tools. Examples of information to be considered and evaluated may include, but are not limited to, the following: an appropriately detailed evaluation of mental, physical, psychosocial, and functional status, including comorbid conditions and pertinent psychiatric symptoms and diagnoses, and a description of resident complaints, symptoms, and signs including the onset, scope, frequency, intensity, precipitating factors, and other important features. Each resident's goals and preferences, allergies to medications and foods, and potential for medication interactions, a history of prior and current medications and non-pharmacological interventions, including therapeutic effectiveness and any adverse consequences, recognition of the need for end-of-life or palliative care, and the basis for declining care, medication, and treatment, and the identification of pertinent alternatives, documentation of indications of distress, delirium, or other changes in functional status, circumstances that warrant evaluation of the resident and medication S include admission or readmission, a clinically significant change in conditions status, a new, persistent, or recurrent clinically significant symptom or problem, a worsening of an existing problem or condition, an unexplained decline in function or cognition, a new medication order or renewal of orders, and an irregularity identified in the pharmacist's medication regimen review. See F756 for guidance related to the medication regimen review. Orders for PRN psychotropic and or antipsychotic medications, which are not prescribed to treat a diagnosed specific condition, or do not meet the PRN requirements for psychotropic and antipsychotic medications. Specific considerations related to these circumstances may include the following: admission or readmission. Some residents may be admitted on medications for an undocumented chronic condition or without a clear indication as to why a medication was begun or should be continued. It is expected that the attending physician, pharmacist, and staff subsequently determine if continuing the medication is justified by evaluating the resident's clinical condition, risks, existing medication regimen, preferences, goals, and related factors. Multiple prescribers, regardless of who the prescribers are, the continuation of a medication needs to be evaluated to determine if the medication is still warranted in the context of the resident's other medications and comorbidities. Medications prescribed by a specialist or begun in another care setting, such as the hospital, need to have a clinically pertinent documented rationale in the resident's medical record. New medication order as an emergency measure when a resident is experiencing an acute medical problem or psychiatric emergency, e.g. the resident's expression or action poses an immediate risk to the resident or others, medications may be required. In these situations, it is important to identify and address the underlying causes of the problem or symptoms. Once the acute phase has stabilized, the staff and prescriber consider whether medications are still relevant. Subsequently, the medication is reduced or discontinued as soon as possible, or the clinical rationale for continuing the medication is documented. If the new medication is a psychotropic or antipsychotic medication ordered on a PRN basis, the PRN orderess must be consistent with the requirements for PRN use of psychotropic and antipsychotic medications at Section 483.45E3, 4, and 5. When psychopharmacological medications are used as an emergency measure, adjunctive approaches, such as individualized, non-pharmacological approaches and techniques must be implemented. Longer-term management options should be discussed with the resident, their family, and / or representative S. Psychiatric disorders or expressions and / or indications of distress. As with all symptoms, it is important to seek the underlying cause of the distress. Some examples of potential causes include delirium, pain, psychiatric, or neurological. Illness, environmental or psychological stressors, dementia, or substance intoxication or withdrawal. Non-pharmacologic approaches, unless clinically contraindicated, must be implemented to address expressions or indications of distress. However, medications may be effective when the underlying cause of a resident's distress has been determined, non-pharmacologic approaches to care have been ineffective, or expressions of distress have worsened. Medications may be unnecessary and are likely to cause harm when given without a clinical indication, at too high of a dose, for too long after the resident's distress has been resolved, or if the medications are not monitored. All approaches to care, including medications, need to be monitored for efficacy, risks, benefits, and harm and revised as necessary. Note: permission given by or a request made by the resident and / or representative does not serve as a sole justification for the medication itself. Dose: medications are prescribed based on a variety of factors including the resident's diagnosis, signs and symptoms, current condition, age, coexisting medication regimen, review of lab and other test results, input from the IDT about the resident, including the resident's preferences and goals, the type of medication and therapeutic goals being considered or used. The route of administration influences a medication's absorption and ultimately the dose received. Examples of factors that can affect the absorption of medications delivered by transdermal patches include skin temperature and moisture, and the integrity of the patch. Similarly, the flow rate of intravenous solutions affects the amount received at a given time. Duplicate therapy is generally not indicated, unless current clinical standards of practice and documented clinical rationale confirm the benefits of multiple medications from the same class or with similar therapeutic effects. Some examples of potentially problematic duplicate therapy include use of more than one product containing the same medication, concomitant use of drugs within the same class, or medications from different therapeutic categories with similar effects or properties. Additionally, the risk for duplication is particularly high during transitions of care, especially if medications are not tracked closely between locations or within the care settings. Documentation is necessary to clarify the rationale for and benefits of duplicate therapy and the approach to monitoring for benefits and adverse consequences. Duration. Periodic reevaluation of the medication regimen is necessary to determine whether prolonged or indefinite use of a medication is indicated. The clinical rationale for continued use of a medication may have been demonstrated in the clinical record, or the staff and prescriber may present pertinent clinical reasons for the duration of use. Regarding PRN medications, it is important that the medical record include documentation related to the attending physician's or other prescribers' evaluation of the resident and of indication specific circumstances for use, and the desired frequency of administration for each medication. As part of the evaluation, gathering and analyzing information helps define clinical indications and provide baseline data for subsequent monitoring. Common considerations for appropriate duration may include a medication initiated as a result of a time-limited condition, for example, delirium, pain, infection, nausea and vomiting, cold and cough symptoms, or itching is then discontinued when the condition has resolved, or there is documentation indicating why continued use is still relevant. Failure to review whether the underlying cause has resolved may lead to excessive duration. A medication administered beyond the stop date established by the prescriber without evidence of clinical justification for continued use of the medication may be considered excessive duration. A medication, which is prescribed on a PRN basis, is requested by the resident and administered by staff on a regular basis, indicating a more regular schedule or other change in medication regimen may be needed. Monitoring for efficacy and adverse consequences. The information gathered during the initial and ongoing evaluations and through conversations with the resident and, as appropriate, his or her family or representative is essential to verify or differentiate the underlying diagnoses or other underlying causes of signs and symptoms. Incorporate into a comprehensive care plan that reflects person-centered medication-related goals and parameters for monitoring the resident's condition, including the likely medication effects and potential for adverse consequences. Examples of this information may include the FDA boxed warnings or warnings of adverse consequences that may be rare, but have sudden onset, or that may be irreversible. If the facility has established protocols for monitoring specific medications, and the protocols are accessible for staff use, the care plan may refer staff to these protocols. Optimize the therapeutic benefit of medication therapy and minimize or prevent potential adverse consequences. Establish parameters for evaluating the ongoing need for the medication, and track progress and or decline towards the therapeutic goal. Sources of information to facilitate defining the monitoring criteria or parameters may include cautions, warnings, and identified adverse consequences from manufacturers' package inserts and boxed warnings, facility policies and procedures, pharmacists, clinical practice guidelines or clinical standards of practice, medication references, and clinical studies or evidence-based review articles that are published in medical and or pharmacy journals. Monitoring and accurate documentation of the resident's response to any medication is essential to evaluate the ongoing benefits as well as risks of various medications. Monitoring should also include evaluation of the effectiveness of non-pharmacological approaches, such as prior to administering PRN medications. Monitoring involves several steps, including identifying the essential information and how it will be obtained and reported. It is important to consider who is responsible for obtaining the information, which information should be collected, and how the information will be documented. The information that is collected depends on therapeutic goals, detection of potential or actual adverse consequences, and consideration of risk factors, such as medication-food interactions, clinical condition, for example, renal disease, properties of the medication, boxed warnings, and residents' history of adverse consequences related to a similar medication. Determining the frequency of monitoring, the frequency and duration of monitoring needed to identify therapeutic effectiveness, achievement of resident goals, and adverse consequences will depend on factors such as clinical standards of practice, facility policies and procedures, manufacturers' specifications, and the resident's clinical condition and choices. Monitoring involves three aspects: periodic planned evaluation of progress toward the therapeutic goals, continued vigilance for adverse consequences, and evaluation of identified adverse consequences. Defining the methods for communicating, analyzing, and acting upon relevant information, the monitoring process needs to identify who is to communicate with the prescriber, what information is to be conveyed, and when to ask the prescriber to evaluate and consider modifying the medication regimen. If the therapeutic goals are not being met or the resident is experiencing adverse consequences, it is essential for the prescriber, in collaboration with facility staff, the pharmacist, and the resident, to consider whether current medications and doses continue to be appropriate or should be reduced, changed, or discontinued. Serum concentration monitoring may be necessary for some medications. Abnormal or toxic serum concentrations must be evaluated for dosage adjustments. If serum concentrations are within normal ranges, each resident should still be evaluated for effectiveness and side effects. Re-evaluating and updating monitoring approaches, modification of monitoring, may be necessary when the resident experiences changes, such as acute onset of signs or symptoms or worsening of chronic disease, addition or discontinuation of medications, and or non-pharmacological approaches. For example, a resident who takes warfarin regularly starts on a medication that interacts with warfarin, therefore more frequent blood work may be needed. Addition or discontinuation of care and services such as enteral feedings, and significant changes in diet that may affect medication absorption or effectiveness or increase adverse consequences. Additional examples of circumstances that may indicate a need to modify the monitoring include changes in manufacturer's specifications, FDA warnings, pertinent clinical practice guidelines, or other literature about how and what to monitor. Adverse consequences related to medications are common enough to warrant serious attention and close monitoring. An HHS Office of the Inspector General OIG report released in February 2014 found approximately 1 in 5 SNF residents experienced at least one adverse event during their SNF stay. 37% of these events were related to medications and were often preventable. See the full report. Adverse events in skilled nursing facilities, national incidence among Medicare beneficiaries, at http://oighhs.gov/OE/report/OE 06-11-00370, PDF. Some adverse consequences may be avoided by following relevant clinical guidelines and manufacturer's specifications for use, dose, administration, duration, and monitoring of the medication. Defining appropriate indications for use, determining that the resident has no known allergies to the medication, is not taking other medications, nutritional supplements including herbal products or foods that would be incompatible with the prescribed medication, and has no condition, history, or sensitivities that would preclude use of that medication. Responding to the resident's reported experience with medications and treatments they have received. The risk for adverse consequences increases with both the number of medications being taken regularly and with medications from specific pharmacological classes, such as anticoagulants, diuretics, psychotropic medications, anti-infectives, and anticonvulsants. 1 Adverse consequences can range from minimal harm to functional decline, hospitalization, permanent injury, and death. Use of a tool, such as the CMS Adverse Drug Event Trigger tool, may assist in identifying resident risk factors and triggers for adverse drug events, as well as in determining whether a facility has systems and processes in place to minimize risk factors and mitigate harm to residents. The tool is available on the CMS Nursing Home Quality Assurance and Performance Improvement website, https://www.cms.gov/Medicare/provider enrollment and certification/CAPI/downloads/adverse drug event trigger tool PDF. Additionally, as part of a facility's CAPI program, a facility may track its use of certain classes of medications, such as antipsychotics, through reports from the long-term care pharmacist, which could identify trends and reduce adverse events. One common adverse consequence is delirium, which presents as an alteration in attention and awareness associated with a change in cognition, not explained by a current or emerging neurocognitive disorder. Delirium may result from medications, as well as other factors including electrolyte imbalances or infections. While delirium is not always preventable, identifying and addressing risk factors may reduce the occurrence. In many facilities, a majority of the residents have dementia. Individuals who have dementia may be more sensitive to medication effects and may be at greater risk for delirium. 2. Delirium may go undiagnosed, be misinterpreted as dementia, or misdiagnosed as a psychiatric disorder, such as bipolar disorder. Delirium develops rapidly over a short period of time, such as hours or days, and usually follows a fluctuating course throughout the day. Additionally, the resident may have difficulty paying attention and be less aware of his or her surroundings. Delirium can be characterized as hyperactive e.g., extreme restlessness, climbing out of bed, hypoactive e.g., sluggish and lethargic, or mixed e.g., normal level of activity with lowered awareness. Delirium is particularly common post-hospitalization. Signs and symptoms may be subtle and therefore are often missed. Although generally thought to be short-lived, delirium can persist for months. Recognizing delirium is critical, as failure to act quickly to identify and treat the underlying causes may result in poor health outcomes or death. Negative psychosocial outcomes can also occur in relation to unnecessary medications, including psychotropic medications. These adverse consequences may include suicidal ideation, recurrent debilitating anxiety, extreme aggression or agitation, significant decline in former social patterns, social withdrawal, psychomotor agitation or retardation, inability to think or concentrate, and apathy. Psychotropic medications and antipsychotic medications, F758, only guidance. In accordance with Section 483.45d4, and as clarified in the section above on indication for use, residents must not receive any medications which are not clinically indicated to treat a specific condition. The medical record must show documentation of the diagnosed condition for which a psychotropic medication is prescribed. Section 483.45e1. All medications included in the psychotropic medication definition may affect brain activities associated with mental processes and behavior. Use of psychotropic medications, other than antipsychotics, should not increase when efforts to decrease antipsychotic medications are being implemented. Risks associated with psychotropic medications still exist regardless of the indication for their use, e.g., nausea, insomnia, itching. Therefore, the requirements pertaining to psychotropic medications in Section 483.45e apply to the 4 categories of drugs: antipsychotic, antidepressant, anti-anxiety, and hypnotic listed in Section 483.45c3, without exception. Other medications not classified as antipsychotic, antidepressant, anti-anxiety, or hypnotic medications, can also affect brain activity and should not be used as a substitution for another psychotropic medication listed in Section 483.45C3. Unless prescribed with a documented clinical indication, consistent with accepted clinical standards of practice, and in accordance with Section 483.45D4. Categories of medications which affect brain activity include antihistamines, anticholinergic medications, and central nervous system agents used to treat conditions such as seizures, mood disorders, pseudoablebar effect, and muscle spasms or stiffness. The requirements pertaining to psychotropic medications apply to these types of medications when their documented use appears to be a substitution for another psychotropic medication, rather than for the original or approved indication. For example, if a resident is prescribed valproic acid and the medical record shows no history of seizures, but there is documentation that the medication is being used to treat agitation or other expressions of distress, then the use of valproic acid should be consistent with the psychotropic medication requirements under Section 483.45E. Residents who take these medications must be monitored for any adverse consequences, specifically increased confusion or oversedation, as required by Section 483.45D3. Concerns related to the use of the medications noted here would be investigated at F757, unnecessary medications, if the medication is being used for its original or approved indication and not primarily as a psychotropic medication. The regulations and guidance concerning psychotropic medications are not intended to supplant the judgment of a physician or prescribing practitioner in consultation with facility staff, the resident and his or her representatives, and in accordance with appropriate standards of practice. Rather, the regulations and guidance are intended to ensure psychotropic medications are used only when the medication S is appropriate to treat a resident's specific, diagnosed, and documented condition, and the medication S is beneficial to the resident. As demonstrated by monitoring and documentation of the resident's response to the medication S, concerns related to inappropriate prescribing of psychotropic medications may require referrals by the facility and or the survey team to state medical boards or boards of nursing. Note, CMS is aware of situations where practitioners have potentially misdiagnosed residents with a condition for which antipsychotics are an approved use, e.g., new diagnosis of schizophrenia, which would then exclude the resident from the long-stay antipsychotic quality measure. For these situations, please refer to the following regulations. Section 483.21b3I, F658, to determine if the practitioner's diagnostic practices meet professional standards. Section 483.20G, F641, to determine if the facility completed an assessment which accurately reflects the resident's status. Use of psychotropic medications in specific circumstances, acute or emergency situations. When a psychotropic medication is being initiated or used to treat an emergency situation, i.e., acute onset or exacerbation of symptoms, or immediate threat to health or safety of resident or others related to a documented condition or diagnosis. A clinician in conjunction with the IDT must evaluate and document the situation to identify and address any contributing and underlying causes of the acute condition and verify the need for a psychotropic medication. Use of psychotropic medication to treat an emergency situation must be consistent with the requirements regarding PRN orders for psychotropic and antipsychotic medications, and any continued use must be consistent with the requirements for gradual dose reduction, GDR. Enduring conditions. Psychotropic medications may be used to treat an enduring, i.e., non-acute, chronic, or prolonged condition. Before initiating or increasing a psychotropic medication for enduring conditions, The resident's symptoms and therapeutic goals must be clearly and specifically identified and documented. Additionally, the facility should ensure that the resident's expressions or indications of distress are not due to a medical condition or problem, e.g., pain, fluid or electrolyte imbalance, infection, obstipation, medication side effect, or polypharmacy that can be expected to improve or resolve as the underlying condition is treated or the offending medications are discontinued. Not due to environmental stressors alone, e.g., alteration in the resident's customary location or daily routine, unfamiliar care provider, hunger or thirst, excessive noise for that individual, inadequate or inappropriate staff response that can be addressed to improve the symptoms or maintain safety. Not due to psychological stressors alone, e.g., loneliness, taunting, abuse, anxiety or fear stemming from misunderstanding related to his or her cognitive impairment, e.g., the mistaken belief that this is not where he/she lives or inability to find his or her clothes or glasses. Unaddressed sensory deficits that can be expected to improve or resolve as the situation is addressed, and the medical record must contain clear documentation that the resident's distress persists and his or her quality of life is negatively affected, and unless contraindicated, that multiple non-pharmacological approaches have been attempted and evaluated in any attempts to discontinue the psychotropic medication. New admissions. Many residents are admitted to a SNF/NF already on a psychotropic medication. The medication may have been started in the hospital or the community, which can make it challenging for the IDT to identify the indication for use. However, the attending physician, in collaboration with the consultant pharmacist, must reevaluate the use of the psychotropic medication and consider whether or not the medication can be reduced or discontinued upon admission or soon after admission. Additionally, the facility is responsible for pre-admission screening for mental illness and intellectual disabilities. See Section 483.20K, F645, and F646, and obtaining physician's orders for the resident's immediate care. See Section 483.20A, F635. Monitoring of psychotropic medications. When monitoring a resident receiving psychotropic medications, the facility must evaluate the effectiveness of the medications as well as look for potential adverse consequences. After initiating or increasing the dose of a psychotropic medication, the behavioral symptoms must be reevaluated periodically, e.g., at least during quarterly care plan review, if not more often, to determine the potential for reducing or discontinuing the dose based on therapeutic goals and any adverse effects or functional impairment. If the record shows evidence of prescribing multiple psychotropic medications or switching from one type of psychotropic medication to another category of psychotropic medication, surveyors must review the medical record to determine whether the prescribing practitioner provided a rationale. Potential adverse consequences. The facility assures that residents are being adequately monitored for adverse consequences such as general anticholinergic effects, which may include flushing, blurred vision, dry mouth, altered mental status, difficulty urinating, falls, excessive sedation, constipation. Cardiovascular. Signs and symptoms of cardiac arrhythmias such as irregular heartbeat or pulse, palpitations, lightheadedness, shortness of breath, diaphoresis, chest or arm pain, increased blood pressure, orthostatic hypotension. Metabolic. Increase in total cholesterol and triglycerides, unstable or poorly controlled blood sugar, weight gain. Neurologic. Agitation, distress, EPS, neuroleptic malignant syndrome, NMS, Parkinsonism, tardive dyskinesia, cerebrovascular event, e.g., stroke, transient ischemic attack, TIA. If psychotropic medications are identified as possibly causing or contributing to adverse consequences as identified above, The facility and prescriber must determine whether the medication should be continued and document the rationale for the decision. Use of multiple psychotropic medications can increase the risk of adverse consequences and slash or confound the effects of individual medications, although there may be infrequent times when use of multiple psychotropic medications is indicated, such as to treat multiple symptoms of a condition or to address side effects. Additionally, the medical record should show evidence that the resident, family member, or representative is aware of and involved in the decision. In some cases, the benefits of treatment may outweigh the risks or burdens of treatment, so the medication may be continued. Antipsychotic medications. As with all medications, the indication for any prescribed first generation, also referred to as typical or conventional antipsychotic medication, or second generation, also referred to as atypical antipsychotic medication, must be thoroughly documented in the medical record. While antipsychotic medication may be prescribed for expressions or indications of distress, the IDT must first identify and address any medical, physical, psychological causes, and slash or social slash environmental triggers. Any prescribed antipsychotic medication must be administered at the lowest possible dosage for the shortest period of time and is subject to the GDR requirements for psychotropic medications. Antipsychotic medications, both first and second generation, have serious side effects and can be especially dangerous for elderly residents. When antipsychotic medications are used without an adequate rationale, or for the sole purpose of limiting or controlling expressions or indications of distress without first identifying the cause, there is little chance that they will be effective, and they commonly cause complications such as movement disorders, falls with injury. Cerebrovascular adverse events, cerebrovascular accidents, CVA, commonly referred to as stroke, and transient ischemic events and increased risk of death. The FDA boxed warning which accompanies second-generation antipsychotics states, elderly patients with dementia-related psychosis treated with atypical antipsychotic drugs are at an increased risk of death. https://www.fda.gov/drugs/drug safety/post-market drug safety information for patients and providers/UCM 053171. HTM. The FDA issued a similar boxed warning for first-generation antipsychotic drugs, https://www.fda.gov/drugs/drug safety/post-market drug safety information for patients and providers/UCM 124830. HTM. Diagnoses alone do not necessarily warrant the use of an antipsychotic medication. Antipsychotic medications may be indicated if behavioral symptoms present a danger to the resident or others, expressions or indications of distress that are significant distress to the resident. If not clinically contraindicated, multiple non-pharmacological approaches have been attempted but did not relieve the symptoms which are presenting a danger or significant distress, and /3 GDR was attempted, but clinical symptoms returned. If antipsychotic medications are prescribed, documentation must clearly show the indication for the antipsychotic medication, the multiple attempts to implement care plan, non-pharmacological approaches, and ongoing evaluation of the effectiveness of these interventions. Gradual dose reduction for psychotropic medications. The requirements underlying this guidance emphasize the importance of seeking an appropriate dose and duration for each medication and minimizing the risk of adverse consequences. The purpose of the required GDR or tapering of medication is to find an optimal dose or to determine whether continued use of the medication is benefiting the resident. Tapering may be indicated when the resident's clinical condition has improved or stabilized, the underlying causes of the original target symptoms have resolved, and / or non-pharmacological approaches have been effective in reducing the symptoms. There are various opportunities during the care process to evaluate the effects of medications on a resident's physical, mental, and psychosocial well-being, and to consider whether the medications should be continued, reduced, discontinued, or otherwise modified. Examples of these opportunities include: during the monthly medication regimen review, the pharmacist evaluates resident-related information for dose, duration, continued need, and the emergence of adverse consequences for all medications. When evaluating the resident's progress, the attending physician or prescribing practitioner reviews the total plan of care, orders, the resident's response to medication S, and determines whether to continue, modify, or stop a medication. And during the quarterly MDS review, the facility evaluates mood, function, behavior, and other domains that may be affected by medications. The time frames and duration of attempts to taper any medication must be consistent with accepted standards of practice and depend on factors including the coexisting medication regimen, the underlying causes of symptoms, individual risk factors, and pharmacologic characteristics of the medications. Some medications, e.g., antidepressants, sedatives/hypnotics, opioids, require more gradual tapering so as to minimize or prevent withdrawal symptoms or other adverse consequences. Close monitoring while medications are tapered will enable facility staff to determine whether a resident is experiencing side effects, changes in behavior, or withdrawal symptoms that originally prompted prescribing of the drug. However, some residents with specific, enduring, progressive, or terminal conditions such chronic depression, Parkinson's disease psychosis, or recurrent seizures may need specific types of psychotropic medications or other medications which affect brain activity indefinitely. Note, if the resident's condition has not responded to treatment or has declined despite treatment, it is important to evaluate both the medication and the dose to determine whether the medication should be discontinued or the dosing should be altered, whether or not the facility has implemented GDR as required or tapering. Dose reductions should occur in modest increments over adequate periods of time to minimize withdrawal symptoms and to monitor symptom recurrence. Compliance with the requirement to perform a GDR may be met if, for example, within the first year in which a resident is admitted on a psychotropic medication, or after the prescribing practitioner has initiated a psychotropic medication, a facility attempts a GDR in 2 separate quarters with at least 1 month between the attempts, unless clinically contraindicated. Additional information related to gradual dose reduction may be found in the American Psychiatric Association Practice Guidelines on the use of antipsychotics to treat agitation or psychosis in patients with dementia, 2016. https://psychiatryonline.org/doi/full/10.1176/epibooks.9780890426807 app 02 and at https://www.ncbinlmnigov/pmc/articles/pmc 3,119,470/discontinuing medications. For any individual who is receiving a psychotropic medication to treat expressions or indications of distress related to dementia, the GDR may be considered clinically contraindicated for reasons that include, but that are not limited to: the resident's target symptoms returned or worsened after the most recent attempt at a GDR within the facility, and the physician has documented the clinical rationale for why any additional attempted dose reduction at that time would be likely to impair the resident's function or increase distressed behavior. For any individual who is receiving a psychotropic medication to treat a disorder other than expressions or indications of distress related to dementia, for example, schizophrenia, bipolar mania, depression with psychotic features, or another medical condition other than dementia, which may cause psychosis, the GDR may be considered clinically contraindicated for reasons that include, but that are not limited to: the continued use is in accordance with relevant current standards of practice, and the physician has documented the clinical rationale for why any attempted dose reduction would be likely to impair the resident's function or exacerbate an underlying medical or psychiatric disorder. Or, the resident's target symptoms returned or worsened after the most recent attempt at a GDR within the facility, and the physician has documented the clinical rationale for why any additional attempted dose reduction at that time would be likely to impair the resident's function or exacerbate an underlying medical or psychiatric disorder. PRN, orders for psychotropic and antipsychotic medications. In certain situations, psychotropic medications may be prescribed on a PRN basis, such as while the dose is adjusted to address acute or intermittent symptoms, or in an emergency. However, residents must not have PRN orders for psychotropic medications unless the medication is necessary to treat a diagnosed specific condition. The attending physician or prescribing practitioner must document the diagnosed specific condition and indication for the PRN medication in the medical record. Section 483.45E3. The table below explains additional limitations for PRN psychotropic other than antipsychotic medications and PRN antipsychotic medications. Type of PRN, order PRN orders for psychotropic medications, excluding antipsychotics. Time limitation 14 days. PRN, orders for antipsychotic medications only. 14 days. Exception. Required actions. Order may be attending physician. Extended beyond 14 or prescribing days if the attending practitioner should. Physician or document the prescribing rationale for the practitioner believes extended time period. It is appropriate to in the medical record. Extend the order and indicate a specific duration. None. If the attending physician or prescribing practitioner wishes to write a new order for the PRN antipsychotic, the attending physician or prescribing practitioner must first evaluate the resident to determine if the new order for the PRN antipsychotic is appropriate. The required evaluation of a resident before writing a new PRN order for an antipsychotic entails the attending physician or prescribing practitioner directly examining the resident and assessing the resident's current condition and progress to determine if the PRN antipsychotic medication is still needed. As part of the evaluation, the attending physician or prescribing practitioner should, at a minimum, determine and document the following in the resident's medical record. Is the antipsychotic medication still needed on a PRN basis? What is the benefit of the medication to the resident? Have the resident's expressions or indications of distress improved as a result of the PRN medication? Note, report of the resident's condition from facility staff to the attending physician or prescribing practitioner does not constitute an evaluation. Key elements of noncompliance. If any of the elements the sections below involve psychotropic medications, investigate F758. For all other medications, investigate F757. To cite deficient practice at F757 and / or F758, the surveyor's investigation will generally show inadequate indications for use, failure to document a clinical reason or a clinically pertinent rationale for using medication S for a specific resident or for continuing medication S that may be causing an adverse consequence, or prescribing or administering a medication despite an allergy to that medication, or without clarifying whether a true allergy existed, or failure to consider relative risks and benefits or potentially lower-risk medications before initiating medication S that present clinically significant risks, or Failure to provide a clinically pertinent explanation for concomitant use of 2 or more medications in the same pharmacological class, or failure to consider other factors that may be causing expressions or indications of distress before initiating a psychotropic medication, such as an underlying medical condition, e.g., urinary tract infection, dehydration, delirium, environmental lighting, noise, or psychosocial stressors, or administering a psychotropic medication S, which the resident has not previously received, when it is not necessary to treat a specific condition that has been diagnosed and documented in the clinical record, or failure to attempt non-pharmacological approaches, unless clinically contraindicated, in efforts to discontinue psychotropic medications. Note, for concerns related to a medication that involves an inadequate indication for use and evidence, shows the medication is also being used for the purpose of discipline or staff convenience rather than to treat the resident's medical symptoms. Surveyors should evaluate whether evidence shows the medication is being used to sedate the resident or restrict the resident's movement or cognition, and assess compliance with Section 483.10E1 and Section 483.12A2, F605, right to be free from chemical restraints, instead of citing both at F605 and F757 or F758 for. Note, instances of prescribing antibiotics unnecessarily should be cited at Section 483.45D, F757. The findings may support citing F881 as well, in which case the surveyor must also show that the facility is not implementing part or all of the antibiotic stewardship program, e.g., antibiotic use protocols that utilize an infection assessment tool, monitoring of antibiotic use, or feedback and education to prescribing providers. Inadequate monitoring. Failure to monitor the responses to or effects of a medication, or failure to respond when monitoring indicates a lack of progress toward the therapeutic goal, e.g., relief of pain or normalization of thyroid function, or the emergence of an adverse consequence, or failure to monitor for changes in psychosocial engagement resulting from adverse consequences of medications, e.g., resident no longer participates in activities because medication causes confusion or lethargy, or failure to monitor a medication consistent with the current standard of practice or manufacturer's guidelines, or failure to carry out the monitoring that was ordered, or failure to monitor for potential adverse consequences, or failure to consider whether the onset or worsening of symptoms or a change of condition may be related to a medication, or failure to monitor effectiveness of non-pharmacological approaches, unless clinically contraindicated, before prescribing and administering medications. Note, additional information as well as examples of non-pharmacological approaches may be found in other guidance for regulations at Section 483.40, Behavioral Health Services, and Section 483.25, Quality of Care and Quality of Life. Excessive dose, including duplicate therapy. Giving a total amount of any medication at one time or over a period of time that exceeds the amount prescribed by the prescribing practitioner, the amount recommended by the manufacturer's recommendations, clinical practice guidelines, evidence-based studies from medical/pharmacy journals, or standards of practice for a resident's age and condition without a documented clinically pertinent rationale, or failure to consider periodically the continued necessity of the dose or the possibility of tapering a medication, or failure to provide and/or document a clinical rationale for using multiple medications from the same pharmacological class. Failure to consider each resident's clinical condition as a factor in determining an appropriate dose, as adverse consequences may occur even when medication serum concentration levels are in the therapeutic range. Excessive duration. continuation beyond the manufacturer's recommended time frames, the stop date or duration indicated on the medication order, facility-established stop order policies, or clinical practice guidelines, evidence-based studies from medical/pharmacy journals, or current standards of practice, without documented clinical justification, or continuation of a medication after the desired therapeutic goal has been achieved, without evaluating whether there is a continued need for the medication. For example, use of an antibiotic beyond the recommended clinical guidelines or the facility policy without adequate reassessment and evaluation of the resident. Adverse consequences. Failure to act upon, i.e., discontinue a medication or reduce the dose or provide clinical justification for why the benefit outweighs the adverse consequences, or report the presence of adverse consequences. Or failure to monitor for the presence of adverse consequences related to the use of medications, e.g., particularly high-risk medications such as warfarin, insulin, opioids, or medications requiring monitoring of blood work. Or failure to respond to the presence of adverse consequences related to the use of medications, e.g., particularly high-risk medications such as warfarin, insulin, or opioids. Psychotropic medications. Failure to present to the attending physician or prescribing practitioner the need to attempt GDR in the absence of identified and documented clinical contraindications. Or use of psychotropic medications without documentation of the need for the medications to treat a specific diagnosed condition. Or PRN psychotropic medication ordered for longer than 14 days without a documented rationale for continued use. Or failure to implement person-centered, non-pharmacological approaches in the attempt to reduce or discontinue a psychotropic medication. Section 483.40A2 and 483.45E2. Or administering a new PRN antipsychotic medication for which the resident had a previous PRN order for 14 days, but the medical record does not show that the attending physician or prescribing practitioner evaluated the resident for the appropriateness of the new order for the medication. Procedures. Section 483.4, 5D unnecessary drugs, and Section 483.4, 5C3 and E, psychotropic drugs investigating concerns related to medication regimen review, unnecessary medications, and psychotropic medications. Use the unnecessary medications, psychotropic medications, and medication regimen review critical element C pathway, along with the interpretive guidelines when determining if the facility meets the requirements for, and when investigating concerns related to, medication regimen review, unnecessary medications, and psychotropic medications. Review the medications prescription, over-the-counter medications, and nutritional supplements such as herbal products, currently ordered and / or discontinued by the prescriber at least back to the most recent signed recapitulation of all medications. Obtain a copy of the current orders if necessary. Gather information regarding the resident's mental, physical, functional, and psychosocial status, and the medication-related therapeutic goals identified in the care plan as the basis for further review. Use the table below to guide observations, record review, and interviews with the resident or representative and relevant staff. Symptoms and signs described in the table may also be related to a resident's condition or disease. The surveyor may seek clarification about the basis of specific signs and symptoms from the attending physician and / or pharmacist. Symptoms, signs, and conditions that may be associated with medications. Determine if the resident has been transferred to acute care since the last survey and / or has recently, e.g., the previous 3 months experienced a change in condition or currently has signs and symptoms, such as anorexia and / or unplanned weight loss, or weight gain. Apathy, behavioral changes, unusual patterns. including increased expressions or indications of distress, social isolation or withdrawal, bleeding or bruising, spontaneous or unexplained, bowel dysfunction including diarrhea, constipation and impaction, dehydration, fluid/electrolyte imbalance, depression, mood disturbance, dysphagia, swallowing difficulty, falls, dizziness. Or evidence of impaired coordination, gastrointestinal bleeding, headaches, muscle pain, generalized or nonspecific aching or pain, lethargy, mental status changes, e.g., new or worsening confusion, new cognitive decline, worsening of dementia including delirium, inability to concentrate, psychomotor agitation, e.g., restlessness, inability to sit still, pacing, hand-wringing or pulling or rubbing of the skin, clothing, or other objects, psychomotor retardation, e.g., slowed speech, thinking, and body movements. Review for how the IT managed medications for the resident. Review the record including the care plan, comprehensive assessment, and other parts of the record as appropriate to determine whether it reflects the following elements related to medication management for the resident. Clinical indications for use of the medication. Implementation of person-centered, non-pharmacological approaches to care. Dose, including excessive dose and duplicate therapy. Duration, including excessive duration. Consideration of potential for tapering/GDR or rationale for clinical contraindication. Monitoring for and reporting of response to medications and progress toward therapeutic goals and residents' goals, emergence of medication-related adverse consequences. Adverse consequences, if present and potentially medication-related, note if there was. Recognition, evaluation, reporting, and management by the IDTO physician action regarding potential medication-related adverse consequences. Symptoms, signs, and conditions that may be associated with medications, rash, pruritus, respiratory difficulty or changes, sedation excessive, insomnia or sleep disturbance, seizure activity, urinary retention or incontinence. Review for how the IT managed medications for the resident. The resident's goals and preferences for medications and treatments. If observations or record review indicate symptoms or changes in condition that may be related to medications, determine whether the facility considered medications as a potential cause of the change or symptom. Interview the resident, his or her family, and representatives and the IDT as needed to gather information about use of medications and any possible side effects in the nursing home. Evaluate if the resident may have experienced psychosocial harm related to side effects of medications. Did side effects such as sedation, lethargy, agitation, mental status changes, or behavior changes affect a resident's abilities to perform activities of daily living or to interact with others? Cause the resident to withdraw or decline from usual social patterns. Show the resident has decreased engagement in activities. Cause diminished ability to think or concentrate. For a resident who is unable to communicate psychosocial outcomes related to medication side effects, the surveyor should consider how a reasonable person would experience the changes caused by medication side effects, as explained in the Psychosocial Outcome Severity Guide on the CMS Nursing Homes Survey Resources website. Note: this review is not intended to direct medication therapy. However, surveyors are expected to review factors related to the implementation, use, monitoring, and documentation of medications. The surveyor is not expected to prove that an adverse consequence was directly caused by a medication or combination of medications, but rather that there was a failure in the care process related to considering and acting upon such possibilities. If during the course of this review, the surveyor needs to contact the attending physician regarding questions related to the medication regimen, it is recommended that the facility's staff have the opportunity to provide the necessary information about the resident and the concerns to the physician for his or her review prior to responding to the surveyor's inquiries. potential tags for additional investigation. Examples of some of the related requirements that may be considered when concerns have been identified include the following. Section 42, CFR 483.10 G14, F580. Notification of changes O review whether the facility contacted the attending physician regarding a significant change in the resident's condition in relation to a potential adverse consequence of a medication, or if the resident has not responded to medication therapy as anticipated and or indicated. Section 42, CFR 483.10 F552. Planning and implementing care O determine whether the resident was advised of her his medical condition and therapy, and was informed about her his treatment including medications and the right to refuse treatments. Section 42, CFR 483.24 F679. Activities O review whether the facility provides activities that address a resident's needs and may permit discontinuation or reduction of psychotropic medications. Review also whether adverse consequences of medications interfere with a resident's ability to participate in activities. Section 42, CFR 483.24 F676. Activities of daily living O review whether the facility had identified, evaluated, and responded to a new or rapidly progressive decline in function, development, or worsening of movement disorders. Increased fatigue and activity intolerance that affected the resident's ADL ability in relation to potential medication adverse consequences. Section 42, CFR 483.40, F740. Behavioral Health Services O review whether the facility had identified, evaluated, and responded to a change in behavior and or psychosocial changes, including depression or other mood disturbance, distress, restlessness, increasing confusion, or delirium in relation to potential medication adverse consequences. Section 42, CFR 483.30A, F710. Physician supervision O review if the attending physician supervised the resident's medical treatment, including assessing the resident's condition and medications, identifying the clinical rationale, and monitoring for and addressing adverse consequences. Section 42, CFR 483.30B, F711. Physician visits and 42 CFR 483.30C, F712. Frequency of physician visits O review if the attending physician or designee reviewed the resident's total program of care and wrote, signed, and dated progress notes covering pertinent aspects of the medication regimen and related issues. Section 42, CFR 483.70G, F841. Medical Director O review whether the medical director, when requested by the facility, interacted with the attending physician regarding a failure to respond or an inadequate response to identified or reported potential medication irregularities and adverse consequences, and whether the medical director collaborated with the facility to help develop, implement, and evaluate policies and procedures for the safe and effective use of medications in the care of residents. Section 42, CFR Section 483.80A3, F881. Antibiotic Stewardship Program O review whether the facility has developed and implemented their antibiotic stewardship program, e.g. antibiotic use protocols that utilize an infection assessment tool, monitoring of antibiotic use, feedback, and education to prescribing providers. Deficiency categorization. See also the Psychosocial Outcomes Severity Guide on the CMS Nursing Homes Survey Resources website for additional information on evaluating the severity of psychosocial outcomes. Examples of noncompliance that demonstrate severity at Level 4, immediate jeopardy to resident health or safety include, but are not limited to, facility failure to take appropriate action, e.g., suspending administration of the anticoagulant in response to an elevated international normalized ratio inner for a resident who is receiving warfarin, resulting in either the potential or actual need to transfuse or hospitalize the resident. Failure to respond appropriately to an INR level that is above or below the target range for treatment of atrial fibrillation, prevention of deep vein thrombosis DVT or pulmonary embolus, or other documented indication. Failure to recognize developing serotonin syndrome, e.g., confusion, motor restlessness, tremor in a resident receiving a SRI antidepressant, leading to the addition of medications with additive serotonin effect or medication to suppress the symptoms. Failure to recognize and respond to signs and symptoms of neuroleptic malignant syndrome, NMS. In the presence of initial gastrointestinal bleeding, i.e., blood in stool, the failure to recognize medication therapies such as NSAIDs or COX-2 inhibitors, bisphosphonates as potentially causing or contributing to the gastrointestinal bleed, resulting in the continued administration of the medication until the resident required hospitalization for severe bleeding. Failure to recognize that use of an antipsychotic medication, originally prescribed for agitation, has caused significant changes in the resident's quality of life. The resident no longer participates in activities that they previously enjoyed, has difficulty concentrating and carrying on conversations, and spends most of the day isolated in his or her room, sleeping in a recliner or in bed. Continued use of the antipsychotic medication without an adequate clinical indication, GDR attempts, and evidence of non-pharmacological approaches resulted in psychosocial harm. Failure to reevaluate the appropriateness of continued administration of a PRN antipsychotic medication, originally prescribed for acute delirium, which resulted in the likelihood of significant side effects from the medication. Examples of Level 3, actual harm physical or psychosocial that are not immediate jeopardy, include, but are not limited to: the facility failed to evaluate a resident's new medication regimen as the source of a resident's recent nausea. The prescriber then added a medication to treat the nausea, which caused agitation and insomnia. Failure to evaluate a resident for a GDR for a psychotropic medication originally prescribed to treat delirium. Delirium symptoms subsided, but the resident remained drowsy and inactive. Examples of Level 2, no actual harm with a potential for more than minimal harm that is not immediate jeopardy, may include but are not limited to: facility failure to identify and act upon minor symptoms of allergic response to medications, such as a rash with mild itching to the abdomen and no other symptoms, causing minimal discomfort. Facility failure to monitor for response or for the emergence or presence of adverse consequences for a resident who has not yet experienced an adverse consequence or decline in function, such as by monitoring hydration status and basic metabolic profile for a resident receiving diuretics or ACE inhibitors. Severity Level 1. No actual harm with potential for minimal harm. Severity Level 1 does not apply for this regulatory requirement because the failure of the facility to provide appropriate care and services to manage the resident's medication regimen to avoid unnecessary medications and minimize negative outcome places residents at risk for more than minimal harm. Resources and tools. The following resources and tools provide information on medications, including box warnings, appropriate dosing, medication categories, drug interactions, and medication safety information. Some of these resources also assist in identifying the correct class of a medication, e.g., identifying whether a medication is an antipsychotic or other category of psychotropic medication. Additionally, the list includes some of the recognized clinical resources available for understanding the overall treatment and management of medical problems, symptoms and medication consequences and precautions. U.S. Department of Health and Human Services, National Institute of Mental Health website, which includes publications and clinical research information www.nimnigov. Medline Plus, https://www.nlmnigov/medlineplus/druginformation HTML. National Library of Medicine Drug Information Portal, http://druginfo/nlmnigov/drugportal/drug/categories medication class information. The Food and Drug Administration, FDA webpage, MedWatch. The FDA Safety Information and Adverse Event Reporting Program, http://www.fda.gov/safety/medwatch/default/htm. The University of Maryland Medical Center Drug Interaction Tool, http://umedu/health/medical/drug interaction tool. American Medical Directors Association, www.amdcom. American Society of Consultant Pharmacists, www.askcom. This list is not all-inclusive. CMS is not responsible for the content or accessibility of pages found at these sites. URL addresses were current as of the date of this publication. One Handler, SM. Wright, RM. Ruby, CM. Hanlon, JT. 2006. Epidemiology of Medication-Related Adverse Events in Nursing Homes. The American Journal of Geriatric Pharmacotherapy, 4, pp. 264-272. Retrieved from http://www.science.com/science/article/pi/s1 Tu Fong, T.G. Davis, D. Groudon, M.E. Albuquerque, A. Inouye, S.K. 2015. The Interface Between Delirium and Dementia in Elderly Adults. The Lancet, 14, pp.823-832. Retrieved from http://thelancetcom/journals/lenore/article/PIs 1474-44 2215-00-101-5/. Atypical antipsychotic use in patients with dementia. Managing safety concerns. The American Journal of Psychology, 169, pp. 900-906. Retrieved from http://adjpsychiatryonline.org/doy/full/10.1176/apiadj.2012.120303342. Tag F759. Section 483.4, 5F medication errors. The facility must ensure that its Section 483.4, 5F1 medication error rates are not 5% or greater, and Tag F760. The facility must ensure that its Section 483.4, 5F2 residents are free of any significant medication errors. Definitions: medication error means the observed or identified preparation or administration of medications or biologicals, which is not in accordance with 1. The prescriber's order. 2. Manufacturer's specifications, not recommendations regarding the preparation and administration of the medication or biological. Or 3. Accepted professional standards and principles which apply to professionals providing services. Accepted professional standards and principles include the various practice regulations in each state and current commonly accepted health standards established by national organizations, boards, and councils. Significant medication error means one which causes the resident discomfort or jeopardizes his or her health and safety. Criteria for judging significant medication errors, as well as examples, are provided below. Significance may be subjective or relative, depending on the individual situation and duration, e.g., constipation that is unrelieved because an ordered laxative is omitted for 1 day, resulting in a medication error, may cause a resident slight discomfort or perhaps no discomfort at all. However, if this omission leads to constipation that persists for greater than 3 days, the medication error may be deemed significant, since constipation that causes an obstruction or fecal impaction can directly jeopardize the resident's health and safety. Medication error rate is determined by calculating the percentage of medication errors observed during a medication administration observation. The numerator in the ratio is the total number of errors that the survey team observes, both significant and non-significant. The denominator consists of the total number of observations, or opportunities for errors, and includes all the doses the survey team observed being administered plus the doses ordered, but not administered. The equation for calculating a medication error rate is as follows. Medication error rate equals number of errors observed divided by the opportunities for errors doses given plus doses ordered, but not given x 100. The error rate must be 5% or greater in order to cite F759. Rounding up of a lower rate, e.g., 4.6% to a 5% rate is not permitted. A medication error rate of 5% or greater may indicate that systemic problems exist. The survey team should consider investigating additional potential noncompliance issues, such as F755, pharmacy services, related to the facility's medication distribution system. Note, significant and non-significant medication errors observed at 5% or greater during the medication administration observation task should be cited at F759. However, any significant medication error, whether or not the error rate is 5% or greater, should be cited at F760. Significant and non-significant medication errors determining significance, the relative significance of medication errors, is a matter of professional judgment. Follow 3 general guidelines in determining whether a medication error is significant or not. Resident condition. The resident's condition is an important factor to take into consideration. For example, a diuretic fluid pill erroneously administered to a dehydrated resident may have serious consequences, but if administered to a resident with a normal fluid balance may not. If the resident's condition requires rigid control, such as with strict intake and output measurement, daily weights, or monitoring of lab values, a single missed or wrong dose can be highly significant. Drug category. If the medication is from a category that usually requires the resident to be titrated to a specific blood level, a single medication error could alter that level and precipitate a reoccurrence of symptoms or toxicity. This is especially important with a medication that has a narrow therapeutic index (NTIIE), a medication in which the therapeutic dose is very close to the toxic dose. Examples of medications with NTI include phenytoin dilantin, carbamazepine tegretol, warfarin calmidin, digoxin lanaxin, theophylline theodure, lithium salts escalith lithibid, and frequency of error. If an error is occurring repeatedly, there may be more reason to classify the error as significant. For example, if a resident's medication was omitted several times, it may be appropriate, depending on consideration of resident condition and medication category, to classify that error as significant. See dose reconciliation technique to the observation technique below. Significant medication errors are cited at F760 in the following circumstances. When the surveyor observes a significant medication error during a medication preparation and/or administration, regardless of whether the overall facility error rate is 5% or greater. When the surveyor identifies a significant medication error during the course of a resident record review. While observation is the preferred method for citing medication errors, the surveyor may identify medication errors based on evidence from other sources, such as documentation of a change in the resident's condition determined to be due to medication errors, reports from family members that medication was given incorrectly, and investigation supports that a medication error occurred, or discrepancies in the MAR that lead to identification of a medication error. The surveyor must conduct any follow-up investigation to obtain corroborating information regarding the error, such as interviews with the nurse, director of nursing, or the pharmacist, and review other relevant documents. Surveyors should evaluate whether past noncompliance exists using the survey protocol. Medication errors identified through methods other than observation are not counted in the medication pass observation and not cited at F759. But any significant medication errors would be cited at F760 if evidence supports the citation. Examples of significant and non-significant medication errors. Some of the error examples are identified as significant. This designation is based on accepted clinical standards of practice without regard to the status of the resident, because these error examples show a high potential for creating problems for the typical long-term care facility resident. Those errors identified as non-significant have also been designated primarily on the basis of the nature of the medication. Resident status, actual or potential resident response to the error, and frequency of error could cause such errors to be classified as significant. Examples of medication errors in the following tables: S equals significant, NS equals not significant. Omissions: medication ordered, but not administered at least once. Medication order. Significance: metoprolol, succinate 100 mg daily S. Furosemide 40 mg twice daily. S. Trazodone 25 mg at bedtime. NS. Ibuprofen 400 mg, 3 times daily. NS. Artificial tears 2 drops both eyes. NS. 3 times daily. Fiber supplement 1 packet twice. NS. Daily. Multivitamin 1 daily. NS. Calcium carbonate chewable 1 tablet. NS. 3 times a day after meals. Unauthorized medications administered without a physician's order. Medication order. Significance: warfarin 4 mg. S. Amoxicillin 500 mg. S. Allopurinol 100 mg. S. Ferrous sulfate 325 mg. NS. Acetaminophen 325 mg. NS. Wrong dose. Medication order: Digoxin 0.125 mg everyday, morphine sulfate 20 mg/ml, 0.25 ml, calcium carbonate 600 mg. Administered: 0.25 mg, 0.5 ml. 500 mg. Significance: SS. NS. Wrong route of administration. Medication order: neomycin and polymyxin B ear drops 4 to 5 drops to left ear 4 times a day. Administered left eye. Significance: S. Wrong dosage form. Medication order. Administered. Significance: Dilantin capsules 100 mg, prompt phenytoin 100s asterisk. 3 capsules by mouth at mg, 3 capsules by. Bedtime. Mouth at bedtime. Docusate sodium liquid capsule. NS. 100 mg twice daily. Asterisk Park Davis capsules have an extended rate of absorption. Prompt phenytoin capsules. Do not. Wrong medication. Medication order: vibramycin Tums. Administered: vancomycin Oscal. Significance: SNS. Wrong time. Medication order: oxycodone 5 mg 2 tabs 20 min. Before painful treatment: losartan 50 mg daily at 8 a.m. Administered: 2 tabs, given after treatment at 9:30 a.m. Significance: S. NS. Medication errors due to failure to follow manufacturer's specifications or accepted professional standards. Failure to shake well or mix a suspension. The failure to shake a medication that is labeled "shake well" may lead to a diluted dose or overly concentrated dose, depending on the product and the elapsed time since the last shake. Some medications, for example phenytoin, require correct preparation to achieve the desired therapeutic effect. Surveyors may also observe facility staff mixing suspensions that should not be shaken vigorously, but instead rolled. Any rolling motion used is acceptable as long as the suspension appears uniformly milky and the rolling action has not created bubbles, which can affect measurement and administration of the correct dose. Crushing medications, the crushing of tablets or capsules, for which the manufacturer instructs to do not crush, requires further investigation by the surveyor. The Institute for Safe Medication Practices website provides a list of oral dosage forms that should not be crushed, which may be helpful. http://www.isimporg/tools/do not crush PDF. Some exceptions to the do not crush instruction include: if the prescriber orders a medication to be crushed which the manufacturer states should not be crushed, the prescriber or the pharmacist must explain, in the clinical record, why crushing the medication will not adversely affect the resident. Additionally, the pharmacist should inform the facility staff to observe for pertinent adverse effects. If the facility can provide literature from the medication manufacturer or from a peer-reviewed health journal to justify why modification of the dosage form will not compromise resident care. The standard of practice is that crushed medications should not be combined and given all at once via feeding tube. Crushing and combining medications may result in physical and chemical incompatibilities, leading to an altered therapeutic response, or cause feeding tube occlusions when the crushed medications are combined and administered via feeding tube. Flushing the feeding tube between each medication is also standard of practice. A facility is not required to flush the tubing between each medication if there is a physician's order that specifies a different flush schedule because of a fluid restriction. For a resident who requires fluid regulation, the physician's order should include the amount of water to be used for the flushing between crushed medications and administration of medications. Before giving medications via feeding tube, the placement of the feeding tube should be confirmed in accordance with the facility's policy based on current standards of practice. Concerns related to placement and function of the feeding tube should be evaluated under the requirements at Section 483.2, 5G45, F693, enteral nutrition. Lastly, the administration of enteral nutrition formula and administration of phenytoin dilantin must be separated to minimize interaction, according to drug and enteral formula manufacturer recommendations. The surveyor should consider the simultaneous administration of phenytoin and enteral nutrition formula as a medication error. Note: additional information related to administering medications via feeding tube may be found in Aspen Safe Practices for Enteral Nutrition Therapy at https://www.isimporg/tools/articles/Aspen PDF 2009 and http://pensagepubcom/early/2016/11/09/01486071. References to non-CMS sources do not constitute or imply endorsement of these organizations or their programs by CMS or the U.S. Department of Health and Human Services and were current as of the date of this publication. Crushing oral medications to address concerns with physical and chemical incompatibility and complete dosaging. Best practice would be to separately crush each medication and separately administer each medication with food. However, separating crushed medications may not be appropriate for all residents and is generally not counted as a medication error unless there are instructions not to crush the medication S. Facilities should use a person-centered, individualized approach to administering all medications. If a surveyor identifies concerns related to crushing and combining oral medications, the surveyor should evaluate whether facility staff have worked with the resident/representative and appropriate clinicians, e.g., the consultant pharmacist, attending physician, medical director, to determine the most appropriate method for administering crushed medications, which considers each resident's safety, needs, medication schedule, preferences, and functional ability. Giving adequate fluids with medications, administering medications without adequate fluid when the manufacturer specifies that adequate fluids be taken with the medication requires further investigation. Taking medications with inadequate fluid may interfere with the medication working properly. Most medications can be taken with water, but there are exceptions, as further explained below. If the resident declines to take adequate fluid, the facility is not at fault so long as they made a good faith effort to offer fluid and provided any assistance that may be necessary to drink the fluid. Additionally, the surveyor should look for evidence that the IDT considered other medication options or routes of administration for residents who decline to take adequate fluids or who are fluid restricted. For example, the surveyor would count fluids consumed during meals or snacks such as coffee, juice, milk, soft drinks, etc. as fluids taken with the medication, as long as they have consumed within a reasonable time of taking the medication, e.g., within approximately 30 minutes. Medications that are recommended to be given with adequate fluid include, but are not limited to, bulk laxatives, e.g., Metamucil, Fibrol, Seritan, Consul, Citrucil. Alendronate should be taken with 6 to 8 ounces of plain water only. Potassium supplements, solid or liquid dosage forms such as Kayachlor, Chlorves, Kayon, Kalor, Ktab, Kdur, Kalite, Slow K, Clotrix, Micro K, or 10K should be administered with or after meals with a full glass, e.g., approximately 4-8 ounces of water or fruit juice. This will minimize the possibility of gastrointestinal irritation and saline cathartic effect. Medications that must be taken with food or antacids, the administration of medications without food or antacids, when the manufacturer specifies that food or antacids be taken with or before the medication is considered a medication error. The most commonly used medications that should be taken with food or antacids are the non-steroidal anti-inflammatory drugs NSAIDs. There is evidence that older individuals living with multiple diagnoses are at greater risk of gastritis and GI bleeds. Determine if the time of administration takes into account the need to give the medication with food. Nutritional and dietary supplements. Nutritional supplements are medical foods that are used to complement a resident's dietary needs. Examples of these are total parenteral products, enteral products, and meal replacement products, e.g., Ensure, Glucerna, and Promote. Herbal and alternative products are considered to be dietary supplements. They are not regulated by the Food and Drug Administration, e.g., they are not reviewed for safety and effectiveness like medications, and their composition is not standardized, e.g., the composition varies among manufacturers. If a dietary supplement is given to a resident between meals and has a vitamin S as one or more of its ingredients, it should be documented and evaluated as a dietary supplement rather than a medication. For clinical purposes, it is important to document a resident's intake of such substances elsewhere in the clinical record and to monitor their potential effects, as they can interact with other medications. Note, because nutritional and dietary supplements are not considered to be medications for purposes of the medication administration observation, noncompliance with the administration of these products should not be included in the calculation of the facility's medication error rate. The exception to this would be vitamins and minerals, which are generally considered a category of dietary supplements. Medication errors involving vitamins and or minerals should be documented at F759 and counted towards the error rate calculation. Medication errors involving vitamins and minerals would not be considered to be a significant medication error unless the criteria at F760 were met. It is expected that the facility staff, along with the prescriber and consulting pharmacist, are aware of, review for, and document any potential adverse consequences between medications, nutritional supplements, and dietary supplements that a resident is receiving. Medications administered into the eye facility staff must follow the manufacturer's product information for administration instructions. Facility staff must verify the IS into which eye medication will be administered. When observing the administration of eye drops, confirm that the medication makes full contact with the lower conjunctival sac so that the medication is washed over the eye when the resident closes eyelid. The eye drop should not fall onto the cornea, and the tip of the eye drop bottle should not touch any portion of the eye. The eye drop must contact the eye for a sufficient period of time before the next eye drop is administered. The time for optimal eye drop absorption is approximately 3 to 5 minutes. Systemic effects of eye medications may be reduced if the nurse or resident presses the tear duct for 1 minute after eye drop administration, or gently closes the eye for approximately 3 minutes after the administration. For additional information related to administration of eye drops, see http://www.ai.media/media library/pdf%20document/libraries/new website log oyadrop instruction orig hipdf and http://journals.lww.com/nursing/citation/2007/05000/administering eye drops.14 asks. Note: references to non-CMS sources do not constitute or imply endorsement of these organizations or their programs by CMS or the U.S. Department of Health and Human Services, and were current as of the date of this publication. Sublingual medications, if the resident persists in swallowing a sublingual tablet, e.g. nitroglycerin, despite efforts to train otherwise, the facility should endeavor to seek an alternative. Metered dose inhalers MDI. Ensuring that a device is administered correctly is vital to optimizing inhalation therapy. The surveyor would observe the administration of MDIs for the following. Shake the container well. Position the inhaler in front of or in the resident's mouth, alternatively a spacer. Or valved holding chamber may be used. For cognitively impaired residents, many clinicians believe that the closed mouth technique is easier for the resident and more likely to be successful. However, the open mouth technique often results in better and deeper penetration of the medication into the lungs when this method can be used. If more than one puff is required, whether the same medication or a different medication. Follow the manufacturer's product information for administration instructions, including the acceptable wait time between inhalations. Note: if the person administering the medication follows all the procedures outlined above, and there is an isolated failure to administer the medication because the resident is unable to understand the procedure, for example, a resident with dementia, this should not be counted as a medication error. The surveyor would evaluate the facility's responsibility to assess the resident's circumstance and possibly attempt other dosage forms, such as oral dosage forms or nebulizers. If the facility staff repeatedly fail to administer the inhaler due to circumstances related to the resident's condition, then the surveyor would cite a medication error. The surveyor should look for evidence of staff communication with the prescriber or the consultant pharmacist to address inability to administer a resident's medication as prescribed. The surveyor should also investigate appropriate tags related to the circumstances which prevent the administration of an inhaler or other medication such as care of residents with dementia. For concerns related to care of residents with dementia, the surveyor should also consider the requirements at Section 483.40 Behavioral Health Services. Determining medication errors, timing errors. If a medication is prescribed before meals AC and administered after meals PC, always count this as a medication error. Likewise, if a medication is prescribed PC and is given AC, count as a medication error. Count a wrong time error if the medication is administered 60 or more minutes earlier or later than its scheduled time of administration, but only if that wrong time error can cause the resident discomfort or jeopardize the resident's health and safety. Counting a medication with a long half-life, e.g. Digoxin, as a wrong time error when it is 15 minutes late is improper because this medication has a long half-life beyond 24 hours and 15 minutes, has no significant impact on the resident. The same is true for many other wrong time errors, except AC and PC errors. To determine the scheduled time, examine the facility's policy relative to dosing schedules. The facility's policy should dictate when it administers AM doses or when it administers the first dose in a 4 times a day dosing schedule. Residents have the right to choose healthcare schedules consistent with their interests and preferences, and the nursing home should gather this information in order to be proactive in assisting residents to fulfill their choices. The adjustment of medication administration times to meet the individual needs and preferences of residents must be considered by the nursing home. However, medication administration scheduling must still consider physician prescription, manufacturer's guidelines, and the types of medication, including time-critical medications. Some medications require administration within a narrow window of time to ensure resident safety or achieve a therapeutic effect, while other medications are not affected by a more flexible schedule. Additionally, a facility may, for example, set up a medication ordered twice a day bid on a different schedule for one resident than for another resident, based upon individual preferences. Prescribers' orders. The latest recapitulation of medication orders is sufficient for determining whether a valid order exists provided the prescriber has signed the recap. The signed recap, if the facility uses the recap system, and subsequent orders constitute a legal authorization to administer the medication. Omitted dose. One of the most frequent types of errors is a dose of medication that is ordered but not given omitted. If a surveyor detects an omitted dose, investigate the omission further through interviews with the responsible personess and / or his or her supervisor, and all relevant individuals if a medication cart is shared. Ask the person administering medications, if possible, to describe the system for administering the medications given. Occasionally, a respiratory therapist may administer inhalers. A designated treatment person may only administer topical treatments. A hospice nurse may administer hospice medications. Another person may administer eye drops or as-needed medications, etc. Investigative procedures use the Medication Administration Observation Facility task, as appropriate, along with the interpretive guidelines, when determining if the facility meets the requirements for or investigating concerns related to medication administration and medication errors. Medication, administration, observation, methodology. The survey team should observe the administration of medications on several different medication passes to capture different staff members who administer medications, as well as multiple routes and times of administration. However, when observing medication pass for one resident at a specific time, plan to observe all of the medications prescribed to be given at that time for that resident. Following this process will help to identify if omissions have occurred, record what is observed, and reconcile the record of observation with the prescriber's medication orders to determine whether or not medication errors have occurred. Paper review may help identify possible errors. However, detection of blank spaces on a medication administration record does not alone constitute the occurrence of actual medication errors. The surveyoress conducting medication observation will need to follow up on any observed concerns through additional record review and interviews. Observation technique. The survey team must know what medications, in what strength, dosage forms, and administration route are being administered. This is accomplished prior to medication administration and may be done in a number of ways depending on the medication distribution system used, e.g. unit dose, vial system, punch card. Medication preparation and administration observation 1. Identify the medication by observing the label. When a punch card or unit dose system is used, the survey team can usually observe the label and adequately identify the medication. For multi-medication packet systems, staff identify medications by dose and descriptions provided by the pharmacy. Ask the nurse how medication S being administered is identified so the resident receives the correct medication S. 2. Observe and record the administration of medications pass. Findings at this juncture should be focused on what the surveyor observes, not what the medication administration record states. Follow the person administering medications and observe residents receiving medications, e.g., actually swallowing oral dosage forms. Be neutral and as unobtrusive as possible during this process. The surveyor should ask appropriate staff to explain the facility policy or system. For the identification of residents, multiple tablets or capsules required to deliver a dose of a single medication. Count as one observation and one opportunity for error if medications are crushed prior to administration. Ask staff how they know the medication is permitted to be crushed. Observe whether the crushed medications are combined for administration via feeding tube and flushed between each medication. If so, the number of errors would equal the number of medications that were combined. For example, if 4 medications were crushed and combined to be administered all at once via feeding tube, then 4 errors have occurred before the medications have been administered. Observe infection prevention practices by staff administering medications, including the procedures used for insulin pens and single-dose vial use. In addition to the disinfection of blood glucose monitors (BGMs), if the staff administering medications fail to use appropriate infection prevention and control standards of practice, it should also be evaluated under Section 483.80, Infection Prevention and Control Program. 3. Reconcile the surveyor's record of observation with physician or prescribing practitioner orders. Compare the record of observation with the most current orders for medications. For each medication on the surveyor's record of observation, determine if the medication was administered. According to a valid prescriber's order S. To the correct resident. At the correct time. In the correct dose. By the correct route. And according to correct accepted standards of practice and manufacturers. Specifications. For medications not on the surveyor's list, examine the record for medication. Orders that were not administered and should have been. Such circumstances may represent omitted doses, one of the most frequent types of errors. The surveyor should now have a complete record of what was observed and what should have occurred according to the prescriber's orders. Determine the number of errors by adding the errors on each resident. Before concluding for certain that an error has occurred, discuss the apparent error, if possible, with the person who administered the medications, as there may be a logical explanation for an apparent error. For example, the surveyor observed that a resident had received Lasix 20 mg, but the order was for 40 mg. This was an apparent error in dosage, but the nurse showed the surveyor another more recent order which discontinued the 40 mg order and replaced it with a 20 mg order. 4. Reporting errors at the exit conference, the survey team describes to facility staff each error that they detected. The survey team is not required to analyze the errors and come to any conclusions on how the facility can correct them. Do not attempt to categorize errors into various classifications, e.g., wrong dose, wrong resident. Stress that an error occurred and that future errors must be avoided. Intervening during medication administration, there may be times when the surveyor should intervene before the person administering the medication makes a suspected medication error. This would occur in the event the surveyor becomes aware of the concern before reconciling the medication administration observations with the physician's orders. Examples of this may include, but are not limited to, situations where the surveyor understands that the resident is about to receive an unusually large dose of medication, a medication via the wrong route, such as ear drops in the eyes, or an inaccurate amount of medication difference in what was seen prepared versus what the staff member stated they were preparing, such as amount of insulin. When the surveyor encounters such a situation, he or she should bring it to the attention of the person about to administer the medication. The timing of this would take place at the point in which that person has committed to administering the medication, such as upon entering the resident's room or approaching the resident. The surveyor should question the person away from the resident, such as at the medication cart or in the medication room, in a way that is respectful of the person administering medication and will not bring unnecessary alarm to the resident. The intent is to confirm whether a medication error, significant or non-significant, was or was not about to occur. If a surveyor intervened prior to medication reconciliation to prevent a medication error from occurring, each potential medication error would be counted toward the facility's medication error rate. If the error is discovered later by the surveyor during the medication reconciliation, the observation would still be counted toward the facility's medication error rate. The facility is responsible for ensuring that medication error rates are not 5% or greater, and that residents are free of any significant medication errors. Dose reconciliation technique supplement to the observation technique. When an omission error has been detected through the observation technique, the dose reconciliation technique can sometimes enable the survey team to learn how frequently an error has occurred in the past. Learning about the frequency of an error can assist in judging the significance of the error. See significant and non-significant medication errors above. The dose reconciliation technique requires a comparison of the number of doses remaining in a supply of medications with the number of days the medication has been in use and the directions for use. For example, if a medication was in use for 5 days with direction to administer the medication 4 times a day, then 20 doses should have been used. If a count of the supply of that medication shows that only 18 doses were used, i.e., 2 extra doses exist and no explanation for the discrepancy exists, e.g., resident declined the dose or resident was hospitalized, then 2 omission errors may have occurred. The surveyor should investigate further through interviews and record review to determine if actual medication errors occurred. Use the dose reconciliation technique when the number of medications received and the date and the specific pass when that particular medication was started are captured in the resident's medical record. Unless this information is available, do not use this technique. If this information is not available, there is no federal authority under which the survey team may require it, except for controlled drugs. Tag F761. Section 483.4, 5G, Labeling of Drugs and Biologicals. Drugs and biologicals used in the facility must be labeled in accordance with currently accepted professional principles and include the appropriate accessory and cautionary instructions and the expiration date when applicable. Section 483.4, 5H, Storage of Drugs and Biologicals. Section 483.4, 5H1, in accordance with state and federal laws, the facility must store all drugs and biologicals in locked compartments under proper temperature controls and permit only authorized personnel to have access to the keys. Section 483.4, 5H2, the facility must provide separately locked, permanently affixed compartments for storage of controlled drugs listed in Schedule Roman II of the Comprehensive Drug Abuse Prevention and Control Act of 1976, and other drugs subject to abuse. Except when the facility uses single-unit package drug distribution systems in which the quantity stored is minimal and a missing dose can be readily detected. Intent Section 483.4, 5G, Labeling of Drugs and Biologicals, and Section 483.4, 5H, Storage of Drugs and Biologicals. The intent of this requirement is that the facility, in coordination with the licensed pharmacist, provides for accurate labeling to facilitate consideration of precautions and safe administration of medications, and safe and secure storage including proper temperature controls, appropriate humidity and light controls, limited access, and mechanisms to minimize loss or diversion of all medication. Note, for purposes of this guidance, references to the pharmacist mean the licensed pharmacist, whether employed directly by the facility or through arrangement. Definitions Section 483.4, 5G, Labeling of Drugs and Biologicals, and Section 483.4, 5H storage of drugs and biologicals. Biologicals are made from a variety of natural sources, human, animal, or microorganisms. Biologics are used to treat, prevent, or diagnose diseases and medical conditions. They may include a wide range of products such as vaccines, blood and blood components, allergenics, somatic cells, gene therapy, tissues, and recombinant therapeutic proteins. Controlled medications are substances that have an accepted medical use medications, which fall under U.S. Drug Enforcement Agency D Schedules Roman IIv, have a potential for abuse, ranging from low to high, and may also lead to physical or psychological dependence. Guidance Section 483.4, 5G labeling of drugs and biologicals, and Section 483.4, 5H storage of drugs and biologicals. Labeling of medications and biologicals. This section requires facility compliance with currently accepted labeling requirements, even though the pharmacies are responsible for the actual labeling. Labeling of medications and biologicals dispensed by the pharmacy must be consistent with applicable federal and state requirements and currently accepted pharmaceutical principles and practices. Although medication delivery and labeling systems may vary, the medication label at a minimum includes the medication name, generic and / or brand, prescribed dose, strength, the expiration date when applicable, the resident's name, and route of administration. The medication should also be labeled with or accompanied by appropriate instructions and precautions such as shake well, take with meals, do not crush, special storage instructions. For medications designed for multiple administrations, e.g., inhalers, eye drops, the label identifies the specific resident for whom it was prescribed. When medications are prepared or compounded for intravenous infusion, the label contains the name and volume of the solution, resident's name, infusion rate, name and quantity of each additive, date of preparation, initials of compounder, date and time of administration, initials of person administering medication if different than compounder, ancillary precautions as applicable, and date after which the mixture must not be used. The FDA and the Institute for Safe Medication Practices provide labeling guidance and recommendations aimed at preventing errors. https://www.fda.gov/downloads/drugs/guidance compliance regulatory information /GUID ANSYS /UCM 349009 PDF and https://www.isimporg/tools/guidelines for over-the-counter OTC medications in bulk containers, e.g. in states that permit bulk OTC medications to be stocked in the facility, the label contains the original manufacturer's or pharmacy-applied label indicating the medication name, strength, quantity, accessory instructions, lot number, and expiration date when applicable. The facility ensures that medication labeling in response to order changes is accurate and consistent with applicable state requirements. Additionally, to minimize contamination, facility staff should date the label of any multi-use vial when the vial is first accessed and access the vial in a dedicated medication preparation area. If a multi-dose vial has been opened or accessed, e.g., needle punctured, the vial should be dated and discarded within 28 days unless the manufacturer specifies a different shorter or longer date for that opened vial. If a multi-dose vial has not been opened or accessed, e.g., needle punctured, it should be discarded according to the manufacturer's expiration date. The Centers for Disease Control and Prevention website provides additional information regarding multi-use vials. http://www.cdc.gov/injection/providers/provider fax multivials HTML. Medication access and storage. A facility is required to secure all medications in a locked storage area and to limit access to authorized personnel, for example, pharmacy technicians or assistants who have been delegated access to medications by the facility's pharmacist as a function of their jobs consistent with state or federal requirements and professional standards of practice. Storage areas may include, but are not limited to, drawers, cabinets, medication rooms, refrigerators, and carts. Depending on how the facility locks and stores medications, access to a medication room may not necessarily provide access to the medications. For example, medications stored in a locked cart, locked cabinets, a locked refrigerator, or locked drawers within the medication room. When medications are not stored in separately locked compartments within a storage area, only appropriately authorized staff may have access to the storage area. Access to medications can be controlled by keys, security codes or cards, or other technology such as fingerprints. Schedule Roman IIV medications must be maintained in separately locked, permanently affixed compartments. The access system, e.g. key, security codes used to lock Schedule Roman IIV medications and other medications subject to abuse, cannot be the same access system used to obtain the non-scheduled medications. The facility must have a system to limit who has security access and when access is used. Exception: controlled medications and those medications subject to abuse may be stored with non-controlled medications as part of a single-unit package medication distribution system, if the supply of the medication S is minimal and a shortage is readily detectable. During a medication pass, medications must be under the direct observation of the person administering the medications or locked in the medication storage area/cart. In addition, the facility should have procedures for the control and safe storage of medications for those residents who can self-administer medications. See F755, Section 483.10 C7 for guidance related to the right to self-administer medications. Safe medication storage includes the provision of appropriate environmental controls. Because many medications can be altered by exposure to improper temperature, light, or humidity, it is important that the facility implement procedures that address and monitor the safe storage and handling of medications in accordance with manufacturer's specifications, state requirements, and standards of practice, e.g. United States Pharmacopoeia USP standards. Procedures use the Medication Administration Observation Facility task and the medication storage and labeling critical element pathway, as appropriate, along with the above interpretive guidelines when determining if the facility meets the requirements for or investigating concerns related to medication labeling and storage. Key elements of noncompliance section 483.4, 5G labeling of drugs and biologicals, and section 483.4, 5H storage of drugs and biologicals to cite deficient practice at F761. The surveyor's investigation will generally show that the facility failed to ensure that all drugs and biologicals used in the facility are labeled in accordance with professional standards, including expiration dates and with appropriate accessory and cautionary instructions, or store all drugs and biologicals in locked compartments, including the storage of Schedule Roman IIV medications in separately locked, permanently affixed compartments, permitting only authorized personnel to have access, except when the facility uses single-unit medication distribution systems in which the quantity stored is minimal and a missing dose can be readily detected, or store medications at proper temperatures and other appropriate environmental controls to preserve their integrity. Deficiency categorization, in addition to actual or potential physical harm, always consider whether psychosocial harm has occurred when determining severity level. See Appendix P, Section Roman 4, E, Psychosocial Outcome Severity Guide. Examples of noncompliance that demonstrate severity at Level 4 include, but are not limited to: the facility failed to assure that medications were secure and inaccessible to unauthorized staff and residents. As a result, a resident accessed and ingested medications that caused clinically significant adverse consequences necessitating hospitalization to stabilize the resident. Or, as a result of an incorrect label on the package, staff administered the wrong medication or wrong doses of a medication, e.g., anticonvulsant, antihyperglycemic, benzodiazepine, with a potential for clinically significant adverse consequences, which resulted in or had the potential for serious harm or death, e.g., toxic levels of the medication, unresponsiveness, uncontrolled seizures. An example of level 3, actual harm, physical or psychosocial that is not immediate jeopardy, includes, but is not limited to: medication labeling was incomplete and lacked instructions that the medication was not to be given with specific foods, e.g., milk or milk-based products, resulting in altered effectiveness of the medication and worsening of the resident's symptoms, requiring medical intervention. Examples of level 2: no actual harm with a potential for more than minimal harm that is not immediate jeopardy, may include but are not limited to: the facility's medication cart was not kept locked or under direct observation of authorized staff in an area where residents could access it. No medications were taken by residents, but the potential for more than minimal harm exists. Or, as a result of inaccurate labeling, the resident received the wrong medication or dose, or the correct medication by the wrong route and experienced discomfort, but did not require any interventions. Severity Level 1 considerations: no actual harm with potential for minimal harm. Severity Level 1 does not apply for this regulatory requirement because the failure of the facility to accurately label and safely secure storage of all medications places residents at risk for more than minimal harm. Section 483.50, Laboratory, Radiology, and Other Diagnostic Services. This regulation is intended to ensure that laboratory, radiology, and other diagnostic services meet the needs of residents. That results are reported promptly to the ordering provider to address potential concerns, and for disease prevention, provide for resident assessment, diagnosis, and treatment, and that the facility has established policies and procedures and is responsible for the quality and timeliness of services, whether services are provided by the facility or an outside resource. There are clinical and physiological risks when laboratory, radiology, or other diagnostic services are not performed in a timely manner, or the results of these services are not reported and acted upon quickly. These delays may adversely affect a resident's diagnosis, treatment, assessment, and interventions. If a resident has been adversely affected, refer as appropriate to quality of care, quality of life, abuse, or neglect. Also refer to physician services and nursing services if test results were not acted upon timely as per the facility's policies or the prescribing practitioner orders. There is no tag for this section. Refer to other tags for concerns related to noncompliance. This concludes the reading of Appendix PP. Regulation Section 483.45, tags F755 through F761.